Good afternoon, everybody. Good afternoon, everybody. We are very happy to invite you all for this TANPSYCON 2022, the 37th Annual State Conference of Indian Psychiatric Society Tamil Nadu Chapter. We hope you enjoy the academic feast and the hospitality of both Madurai Psychiatric Chapter and Kodaikanal. Thank you.
Good afternoon, ladies and gentlemen. On behalf of the organizing committee, TANPSYCON 2022, we are greatly privileged to invite one and all of you. A warm welcome to all of you who've gathered here. In the era of increasing expectations from the population, it's very appropriate that you've chosen Pearls and Perils in Psychiatry as a theme of the conference and selected very relevant topics to the practicing psychiatrists. Being here in the Princes of Hill Stations, its climate and natural beauty will be more enchanting to the delegates and will offer a calmness to the beauty and busy practicing psychiatrists. Now, I now call upon, where's this thing? No, I want this. Sabrin Ross, sir. Where's this thing? Yes. No, where's this front page? I now call upon the organizing secretary, Dr. Sabrin Ross, to come over to the stage to give the welcome talk. One more thing, don't have to do, no? Okay, sir. Yes.
Good afternoon, everyone. Good afternoon, everyone. I welcome you all for the first session of this day. I call upon the chairpersons for the first speaker, Dr. A.M. Ashok Kumar sir and Dr. V.K. Aravind sir onto the dais. Ashok Kumar sir, he is a professor at Sri Venkateshwara Medical College Hospital and Research Center, Puducherry. He did his MBBS from Thanjavur Medical College and proceeded to get his MD from Madurai Medical College. He is a former professor and HOD of Raja Muthiah Medical College and also former president of IPS Tamil Nadu chapter during the year 2014 to 15. He was the organizing secretary for midterm CMEs in 2011 and 2019 and also organizing chairman for TANPSYCON 2013 and 2020. He was a fellow of the Indian Psychiatric Society, International Medical Sciences Academy, International Association of Biological Psychiatry, and he has published around 10 papers in national as well as in international journals. For V.K. Aravind sir, sir is a founder of Ram Psychiatry Hospital, Madurai, co-chairperson of SARC Affairs Committee, Indian Psychiatric Society, 2021 to 2022, chairperson of CME Committee, Indian Psychiatric Society South Zone, member committee section of stigma and mental illness in World Psychiatric Association. He has published more than 40 articles in different psychiatry and medical journals. He is international fellow of American Psychiatric Association 2014 in New York, and he was also associate editor in Indian Journal of Psychiatry and assisted in Indian Journal of Psychological Medicine. He has delivered various lectures, seminars, webinars at various international, national, zonal and state conferences, and has also organized zonal psychiatric conference, national level CME programs at Indian Psychiatric Association at Madurai. It's over to you, sir.
Very good afternoon, and thanks for the organizing team for welcoming and asking us, Dr. Ashok sir and myself, to be the first chair of this today's session. And it's a pleasure to see a lot of registration after a very long time after a pandemic episode. And indeed, Madurai Psychiatric Association, on behalf of Madurai Psychiatric Association and all the psychiatrists all over the Tamil Nadu, we welcome you all for the 37th Annual Psychiatric Meet. And straight away going to today's topic, I would like to introduce the speaker. Can you just put the slide of speaker, Asma? Speaker introduction. So we welcome Dr. Avudayappan for today's topic on gender dysphoria. So Dr. Avudayappan is a... Can you put one more chair? So Dr. Avudayappan is an associate professor at Mahatma Gandhi Medical College, Pondicherry. He did his MBBS at IIT Perundurai Medical College in 2007 and completed his MD at Tanjavur Medical College in 2012 with the DNC psychiatry completion in 2015. So he has an experience of assistant surgeon at Kallakkurinji GH, and he's also in charge of DMHP and worked as a district psychiatrist at DMHP Chennai. Also worked as assistant professor at MGMC Pondicherry since 2012 and promoted as associate professor on 2019. And he is also running a private clinic, Manam Tirundu Mental Health Center at Kadalur. And his areas of interest are public health awareness about psychiatry and conducted various programs for teachers, students and people from various walks of life and also in charge of transgender mental health clinic since 2014. And I think he's the right person to talk on this, and I just hand over the mic to my co-chairperson.
I thank the organizing committee for giving me this opportunity to chair this session. The topic is very interesting. Actually, there is a lot of misinformation disseminated regarding gender dysphoric disorder. There are a lot of changes occurred from change of nomenclature and understanding of gender dysphoric disorder. The gender identity disorder has been removed from the DSM. Until DSM it was used as gender identity disorder. Now it is called gender dysphoric disorder. I think Dr. Avudayappan will be the right person to give the concept of the gender dysphoric disorder as well as myths and mysteries regarding the gender dysphoric disorder. I welcome Dr. Avudayappan.
Respected seniors on and off the dais, dear colleagues and friends, good afternoon. At the outset, I would like to thank organizing committee as well as Dr. Kumanan sir for giving me this opportunity. Gender being a less discussed topic in the clinical settings, I am faced with a threefold agenda in this presentation. One, to bring you update with the present and past concepts about gender, and two, about discussing about the gender dysphoria in per se, and three, and about what is the relevance of gender dysphoria to the practicing psychiatrist, what we need to do about that. If you note the title, I have put an apostrophe mark on the disorder. Why this apostrophe mark, and should we have to retain it or remove it, we will see in the course of our presentation. So basically, we will need to understand the concept of gender first. Individual's sexual identity is comprised of four different concepts. The first concept is the biological sex, which is the sex which is given at the birth, and it corresponds to the genitalia, chromosomes, and it is determined by hormones. So this is something which everyone knows, and this is when this is having a malformation, it leads to intersex conditions. And for long, sex and gender has been considered as an interchangeable term. Only in the beginning of early in 20th century, the concept of gender came forth when people started to recognize that there are a subgroup of people for whom the genitalia doesn't mean their gender. So based on their work, the concept of gender identity came forth, which is considered to be more of a socio-cultural phenomena, along with the role of biology being a questionable role of biology, and then any disturbance in this leads to a gender incongruence or gender dysphoria. And the third generally, the concept of sexual identity includes gender role. Gender role is a cultural based thing, and it is determined by the prevailing social norms. It is subsumed under the gender identity, but it can also be different as well. So one thing we need to understand here is a person want to play a gender role doesn't need to necessarily have a gender identity issue. So we have seen many people who have just cross dressers, who just cross dress at their private places, but they don't want to be labeled as a person transgender, or neither as a female, neither as female. And then the lastly, sexual orientation, which we all know is the sexual attraction a person has towards say, members of same or opposite or both sexes. So one thing which I want to make very clear on the outset itself is sexual orientation is not gender identity. That is first of all which we need to understand this, because most often we in our clinic we meet up people who are homosexuals who come up with the anxiety that they are being transgender. They are feeling that they are changing over to transgender. So they want to erase their homosexuality. So these sort of presentations we frequently come across. Also, whenever sometimes when we are seeing a transsexual people, when we inquire about their sexual orientations, they declare themselves to be bisexual or homosexual, but still they consider themselves as transsexual. So gender identity and sexual orientation are both distinct phenomena. So to explore the concept of gender, we can see about three different theories. The first one being biological essentialism, which is a primary theory which has been in vogue for many years. Here, that gender is considered as a natural and inevitable, and it's a biologically determined phenomena. So it is an universal phenomena. So if you have a penis, then you are a male, and your gender is male. There is nothing you can feel against it. And there is an essential difference between the male and the female gender. So this essential difference is pervading throughout people, and it is something which is unalterable. So if we take up this view, a lot of gender expressions and gender identities which are violating this biological imperative will be considered as a disorder. So this theory was considered very much too stigmatizing, and it fails to acknowledge the socially constructed nature of the gender. So this theory following this theory, the next theory which came up was in resistance to this is the social constructionist theory. This social constructionist theory started at around 1960s and 70s, when there was a research upsurgence of gay rights and LGBT movement and feminist movement, where the gender became an issue for discussion. So here the social constructionist theory takes a view that all phenomena are socially made, are socially constructed, and gender is one such phenomena. So it is not a biological thing, or either it is something which is coming through a practice, but rather it is coming through a social interaction and social practice. So society has a norm and set rules that an individual has to conform to that, and if they fail to conform to that, then they will be exempted from which. So because of that ostracization, individuals play up to the social norms. So it considers gender as a fluid assemblage. The important word here is the fluid. It is not a consistent or fixed assemblage. It's a fluid assemblage of meanings and behaviors that we construct from the values and images and prescriptions we find in the world around us. So basically we take up the world around us and we see how the men are, and we construct ourselves in their image. So this concept of doing gender was given by West and Zimmerman in around 1960s. What is the word doing gender means? It means that we tend to act in a particular manner to conform to the society, or we tend to do the gender. Gender is not something which is innate, and we do the gender wherever, and in all the situations we need to keep doing the gender to be accepted into the society. So if someone is not doing the gender, then they will be met with ridicule and even in extreme cases violence. So to understand this, if we think back in our school days or college days, how we have reacted to a effeminate person. So we would have seen that most often they will be labeled as some derogatory term, and then they will not be accepted in the mainstream, and they will always be ridiculed, and they will be constantly be told to be acting like a male or acting like to something like an according to that. So these things are social kind of pressures to which the individual has to conform. So this is the doing gender that has been there. So this this basic approach is called a social constructionist approach. The flip side of this approach is that it is considered it doesn't consider biology at all. So the social constructionist theory in sometimes can also be seen as a cultural essentialistic theory, where in biologic essentialism we ignore all the social nature of gender, where a social constructionist approach we ignore all the biological nature of the gender. So this in other words, this is not a much I mean, there are a lot of other theories which came up again after this. So the third wave of theories are postmodernist approaches to the gender. Postmodernism is a philosophical stance. Here they question anything and everything that is considered as an established truth. So gender as an established truth is questioned. So the postmodernistic approach to gender is by queer theory. In the queer theory, they consider identities are natural. Identities are performative. That is, we perform to the crowd, that we perform to the people, and that thereby they are not more fluid in nature. And they are stable only because we repeat the normalized act again and again, and that becomes a stabilized identity. So this basically focuses on anti-essentialist sentiments, and whenever there is an essentialist sentiment coming in, it tends to play up against it. So especially if we take up gender fluid or gender queer, this can never be accounted by biological essentialism, neither by social constructionist theory, but rather this queer theory can help us understand about both the concept. So before moving on, we need to understand certain terminologies. So it will be easier to understand the further discussions. So the first terminology we have to understand is the gender, assigned gender or natal gender, which is the gender which is given at the birth. And then we have cisgender. Cisgender is the male who conforms to a male gender identity. When there is a trans or a female who conforms to a female identity. And there is a transgender where the individual, that's actually an umbrella term which includes both trans male and trans female. The trans male is actually female to male, that is a female whose birth gender is a female but conforms to the male gender identity, and trans female is the male whose birth gender is a male and but conform to a female gender identity. So then there is a concept of gender fluid and gender queer. Gender queer, these are the people who reject the labels of gender, that they consider themselves to be not having any gender, and they reject the gender of labels of gender and sexual orientation. So they use the pronoun me instead of he or she. Then we have gender, agender and gender fluid. So gender, agender people consider themselves they don't have any gender, or they don't feel any gender at all. So they consider themselves to be gender neutral. And then another gender fluid people are the people who can move beyond the identity. That is, at some point of time they feel male, at some other point of time they feel as female. So these are newer terms which have come up in the wake of postmodernistic approach. So coming to the biological causes for transgenderism. From a biological viewpoint, there is no particular physical abnormality or chromosomal abnormalities which can be considered to be causative of trans phenomena. But there are even some studies which suggest that there are even some studies which suggest that gender maybe the development of transgenderism is associated with a biological mechanism mostly, and it is influenced by a social and environmental factors as well. So, having said that, one fact which we know is sexual differentiation of genitalia occurs earlier than the sexual differentiation in the brain. So even in a person who has sexually differentiated genitalia wise, there can be a change in the sexual differentiation, and it occurs in the brain. So there is a biological plausibility for a phenomena of transgenderism, but we are yet to locate the exact cause. So there are three areas of interest when we explore the biological reasons for transgenderism. The first one is neuroanatomic, then is genetic, and then finally hormones. In the neuroanatomic, there are two areas which are very much implicated. The third interstitial nucleus of anterior hypothalamus and central subdivision of the bed nucleus of stria terminalis. But both these areas, the number of neurons which a transgender has corresponds to their cisgender identity which they have adapted. Like for example, a trans male has the same number as a cis male. A trans female has the same number as a cis female. So that is one thing which we have come across. As well as now the shift has been changed to more towards an network hypothesis, where the network of perigenual anterior cingulate cortex, temporoparietal junction, and fusiform body area are considered to be very these connections are considered to be very important in the determination of transgenderism. In the genetic process, we have found that monozygotic twins have got 39% concordance for gender dysphoria, and we have not isolated any candidate gene. Regarding the hormonal causes, we have found that prenatal exposure to hormones and associated with gender dysphoria or transgender phenomena, but we have the evidence is suspect, because we consider two intersex conditions, where is a congenital adrenal hyperplasia and androgen insensitivity syndrome. In congenital adrenal hyperplasia, there is the chromosome makeup is like that of a female, but they are exposed to in utero to a high dose of androgen. So in that case, they should have developed a male identity. But we find that in partial CAH, 94% develop only female identity, and in complete CAH, almost there is like 30 to 40% of people who have developed male identity or assigned male sex at the birth shifts over, have developed gender dysphoria and switch over to female identity. Similarly, in androgen insensitivity syndrome, the individuals are not exposed to androgen and they develop as without any androgen exposure. So when we find that when this diagnosis out, or when they come to an adult stage, we find that most of them, almost 50% of them, convert back to male identity. So there is seem to be a possible biological role in the determination of transgenderism and role of hormone, but we are yet to assign the exact role. So next comes the psychosocial theories. There have been a lot of earlier theories like Freud, Kohlberg. Most of these theories are considering binary nature of gender, that is a male and female, and any other thing is considered as a gender development gone wrong. So these theories are considered pathologizing and currently are not accepted. But the latest model which we have come across is the Lew's model. In the Lew's model, which is a more trans focused model, there are 6 stages. In the first stage, there is an awareness about their transgender identity. When this awareness comes in, then they start to seek information and they start to reach out to their peers and they start to see about their, and then once they realize that there is a transgender, there is an identity of transgender and they can adopt that, then they start to disclose to their significant others. When this disclosure happens, definitely they will be met with resistance from their family and their society. When this starts to happen, then there is an exploration of the further identity and acceptance and self-labeling of themselves as transgender. So when they start to label themselves as transgender, then they next start to seek avenues or explore avenues for transition, which and possible bodily modification. So transition includes just a change in the dresses or cosmetic change or hormonal change or even a surgical correction. So they tend to adapt such conditions, and finally there is an integration and acceptance of post-transition issues. So basically this model is considered a more representative and trans-inclusive model for psychosocial development of transgender. So next we bring up to diagnosis of gender dysphoria. when the DSM-5 committee for sexual disorder was formed, and the expectation was that they might remove, drop transgender and transsexuality from the diagnostic system altogether, just like what we did with homosexuality. But the committee planned to retain the gender dysphoria, gender problem issues, primarily for an insurance purpose, but insurance purpose and for further exploration purpose. But there were significant changes in the DSM-5 terminologies. One, the gender dysphoria was removed from the sexual disorders and they were placed in a separate category, which is of their own. There's a gender dysphoria chapter was formed because they, by clubbing with the sexual disorders, there is a chance that they can be stigmatized as a sexual disorder. So that is one movement, one change we had. And the focus, which was initially on the disorder part, was now changed into a dysphoria part. This dysphoria is considered to be a central thing to make up a diagnosis, and the involvement of the psychiatrist is to address the dysphoria and not to change the gender. So that is the major change we have brought about in the understanding of gender dysphoria. And then the name of the dysphoria has been dropped from the disorder, has been dropped from the name, primarily because it is stigmatizing, as well as the disorder cannot be, and it is not no longer considered as a disorder to be fixed. So it also recognizes the post-transition status, but it's not without any there are a lot of criticism against this diagnosis also. So the primary diagnosis, the criticism is, though they have removed this and placed it in a separate, still it is in the manual. So when it is in the manual, it is still being considered as a part of a mental problem. So that is what is stigmatizing. So they want it to be completely dropped out of the manual and moved to some other criteria. So then, which has been adapted by ICD-11, where they have moved gender incongruence completely from the mental issues, and they have placed it in a separate disorder and chapter on their own. So then the next thing is the adapting the terminology of gender dysphoria. Gender dysphoria is not a new term, it has been there for a long time. So adapting this terminology actually makes no sense. It conveys different meaning to different people. So that is another reason why people were against this. And then by recognizing the post-transition state, they are putting a dilemma here. Because in a post-transition state, the dysphoria might not be there with the individual. The dysphoria might have been resolved. So why we are continuing to hold such people in the diagnostic dilemma? So that is another thing which we have to, which is being criticized against DSM-5. So coming back to my question, in the initial thing, gender dysphoric disorder is a misnomer. Gender dysphoria, that is the only term which is accepted now, and if you want to be more ICD-11 specific, it might be considered as gender incongruence, but gender disorder part is not accepted. So moving on to my last thing, to what is the role of mental health personnels and what is the role which we need to play. So these roles I will be discussing further can be divided in 3 stages. In the first stage, when the client is presenting to us in the pre-transition stage, when they want they are planning to undergo transition, or in a pre-transition stage, when they want to explore their gender further. So when they are presenting to us in a pre-transition stage, there are some role. And when there is another stage of transition stage, where we need to help them with sexual reassignment procedures, with hormone therapy and everything. And then the third part is when they are seeking our help for other issues. So like anxiety disorder or any other mental issues for which they are seeking our help. So there are certain good clinical practices when we are seeing a transgender clients. The first thing which we need to adapt is that we should ask the clients what is their name and the pronouns they wish to use. So we need to explore their gender issues only when the treatment is sought for that gender issues, and when they when they have an important bearing in the diagnosis. In other conditions, this need not be explored in this. And especially we should avoid physical examination of chest and genitalia unless until it is indicated, and that too only with the consent of the patient. So for a pre-transition client, this model, diverse model, is a useful model. So in this, if we see, then it is similar to Lev's model, but it has got more stages and more division. So mostly when client present to us, that will be the stage of identity comparison about transsexuality or identity tolerance of transsexuality. It is this at this point they are very confused. They will be asking us, am I transgender? If I am transgender, then how I am to live in this society and how I am to get integrated into the society. And sometimes they will be brought by the family for us to change the transgender orientation. So it is at this point we need to be very careful, and we need to explore to them along with them the gender concerns, and we need to establish the diagnosis of gender dysphoria. And to address the gender dysphoria, we need to be non-biased, non-judgmental, and ask them to explore in their own pace, what is to be undertaken and what is to be changed. So in this, most often this is not a one step process, it takes more time, multiple consultations would be needed, and once they accept the transgender identity, we need to make them more affirmative and to come out with their change and to assert their change to the society. So this can be accomplished by asking them from a simple name change or a dress change, or coming out in a common in a opposite sex dress. So these are simple steps which can be start, and then slowly when they are comfortable with that, then we explore the options for transition. And when they are ready for the transition, we help them with the transition process and help them with the post transition issues. So especially when we are seeing a client in the pre-transition phase, we need to address the strength and resilience factors of the client. Especially this is important because most often they will have a lot of pressure from their family and other people to conform to their assigned gender. So they will be always going back and forth with sometimes they will be willing to conform, sometimes they will not be hesitant to conform. So this we need to help them address. Only if we address their resilience factors and help them face the issue, we can help them come out with their options. And then we should acknowledge the conflicts within the client and reassure they are part of the transition process. And we need to accept the decisions by the client, and we should never push them to take decisions. Just because we feel that they are taking a long time to make up a decision, we need not push them towards a decision. Also, should be very careful when they are rushing towards a decision. We need to make them take some more time and come to make an informed decision, and sometimes we need to act as a brake at that point. We need to put forward the options of transition and explore the way forward. Also, we need to enhance support system. Most often when they are brought by the family, we need to explore with the family members about accepting the transgender identity and an ability to come out and face the transgender identity as a family. So that should be undertaken. For a transitioning client, a client who's come out with their identity, confirmed to their identity, and they want to transition, it starts with the completely reversible steps like change of name, then change in the manner of dress where they want to come out with the dress, and then there is a partial reversible changes like cosmetic surgeries or hormone therapy, and then irreversible gender affirming surgeries can be undertaken. So these are flexible and they are based on patient choice. So decision when to undertake transition or not does not validate the diagnosis. That is something which we need to tell the patients again and again, because most often the patients feel pressurized to undertake transition because they want to prove that they are transgenders. A transgender without surgery, then what is he? That is a question they frequently ask. If I am not undergoing surgery, if I am still with my genitalia, then how can I consider myself to be the member of opposite sex? But that is not the issue. Gender is something which we feel, it is personal. So we need not undertake any change to prove that to any others. So if we are comfortable, then we can go forward with the transition. So for transitions, there are not much guidelines available in WHO or any other society have not put forth much guidelines. So we are following WPATH guidelines, World Association for Transgender Health WPATH guidelines, which are considered as a currently accepted standard of care. They are the seventh version, and it has been 9 years almost almost a decade since they have published these guidelines. So there have been lot of changes, but still this is the newer guidelines will be awaited this year. But these guidelines, whatever has been given, is applicable still now. So for them, the guidelines which recommend for a hormone therapy and for a breast or chest surgery, one consultant opinion is enough. If we need to give them only one consultant opinion is enough. And in that, the primary issues are to confirm the diagnosis of gender dysphoria, make sure we need to make them have a capacity assessment about their decision-making capacity, informed consent capacity, and to confirm their age of majority, and to rule out the comorbid medical and mental health conditions. But when we go for genital surgeries, the genital surgeries require, or the recommendations for genital surgeries are still a bit more stricter. Here, the genital surgeries require 2 consultations, and these 2 consultations, 2 different referrals, and when they are undertaking these referrals, there need to be the following factors should be observed. Like one, they should confirm to the diagnosis of gender dysphoria, informed consent capacity, and age of majority, as like that of a previous thing. But still, the 2 other things comes in. They need to have 1 year of hormone therapy and 1 year of living in role. These 2 are conditions which are very difficult to interpret. So what are the problems with this standard of care are this 1 year of living the role. What is mean by living the role? The individual should adapt the dress, manners, and they live in that particular gender which they want to assert. Say for example, if a male wants to transition to a female, they need to adapt the female dress, and they should go out with the female dress, and they should be able to socialize with that, and they should adapt to that. Why this criteria is put forward is because frequently they find that unless until they have a real life experience of living in that other role, they feel that the possibility of regret post surgery might be high. But after this criteria has come out, there have been a lot of literature reviews and other things which have proven that this is not a necessary phenomena. So living in role might be removed in the next criteria, but we are not at next version, we are not yet sure. So then we need to have multiple consultation from 2 different psychiatrists. So this acts more like a gatekeeper phenomena. So we need to go to getting a consent from one psychiatrist itself is a difficult thing. So getting consent from 2 different psychiatrists, it is again going to be a difficult thing. And then there is a need for hormone therapy. The hormone therapy may be freely available for people in Western countries, but in our countries, so there is a lot of issues with hormone therapies, and this they need to have a lot of investigations and other things for which our transgender people, transgender clients are not able to accept that. So this criteria is not in keeping with the cultural demands of our population. So in our unit, we have developed this model of assessment for sex reassignment surgery. In this model, we have got first visit. In the first visit, they register themselves with the transgender clinic. Once they register themselves with transgender clinic and they express their wish that I want to undergo sex reassignment surgery, then they are referred to our psychiatric department. In the psychiatric department, we make a diagnosis of gender dysphoria, and we rule out the comorbid mental health conditions, and then we refer them to the surgery department. In the surgery department, they have a discussion about the available transition options and available surgery options. So they might have opt for a simple removal of testes, or they might opt for something like a reconstruction of vaginoplasty, or something in a more clitoroplasty. So those things are discussed. But again, there is a cost factor, and there are other issues which they need to implant factors. All those things need to be addressed. And then they discuss about the complications. What are the complications arising out of the surgery? All these are discussed. Once their discussion is over, then they are referred back to us. This second visit happens in some other day. Usually the day of TG clinic will be in Wednesday, so they come back in the next week on the second visit. In the second visit, we undertake an assessment for eligibility for transgender surgery and assess for the readiness for the transgender surgery. This eligibility we determine with 2 things. One, living in role role experience. Having said so much about living in role experience, why we have retained it? Because we feel that living in role, most of our clients are coming from a nearby Jamaat, that is a transgender community. So most of them have already had a living in experience more than 1 year. They have been in that same role for more than 1 year, and hence that doesn't make much of difference to us. Also, then this sometimes when we have clients who are very rushing to get a sex reassignment surgery, this serves as a like a filter to help them retain and to do more time, give us more time to do therapy. Because we have had clients who have come up with someone else, like some other person who is not a family member, and then demand that they should be assessed for sex reassignment surgery and they should be done now. So these sort of clients, we need this rider to make them understand and come them frequently for a follow-up. So then we assess for readiness. In the readiness, the related leads to that it is important to know that whether they understand the consequences of their treatment, what the treatment will be like. So we have a set of questions for readiness, and this readiness, we ask these questions help us explore their readiness to undergo the transition, whether they have considered their post-transition role, whether they have considered their integration into the society after transition, and whether there are any issues in their life which they might have overlooked. All those we discuss with them, and at the end of which we give them their consent for sex reassignment surgery. The third level stage of clients who have come to our clinic are those with the mental health comorbidities. Mental health comorbidities are higher with the transgender clients because of the minority stress model. They are exposed to more stress, and then that goes into having more of mental health issues, and there is high rates of suicide, almost like 50%, and high rates of relationship issues, which are all the major issues we have seen in our clinic. So having said that, we would believe that they will be more than willing to accept trans and mental health opinion when it is offered. But what we have found is that there is a huge resistance to seeking for a mental health, seeking for a psychiatrist opinion, primarily because of the double stigma. Already they are bearing a stigma of transgender identity. They don't want to bear another stigma due to mental health issues. Also, there is a fear of transphobia, where they have met with a lot of people who have, especially in doctors and other earlier areas, where they have met with transphobia. So they are worried that the transphobia might be exhibited even by us. So then there is a refusal to accept the medical model, where they feel that this needs to be discussed and addressed only within their community, within something which needs to be resolved on their own, and they are unwilling to accept for medications or neither with even therapies. So finally, then most of our clients, they are coming from a very poor background. They are actually, their livelihood is primarily with begging or with the prostitution. So most of them, they don't have money to come again and again, as well as they don't have time to be with us. If they come to our hospital, it will be one day off. So that night their work will get spoiled. So they don't feel like coming to it frequently. So these are the issues we have faced with clients who have come for this, for the other reasons. So in conclusion, whether gender dysphoria is a myth or illness, my answer to this will be, to call something as a myth or something as non-existence, we should have known it first. That self-perception is very important before we brand it as non-existent. When such a gender dysphoria cannot be assessed by or cannot be felt by us, then how can we call it as a myth? So calling it as myth would be more stigmatizing and more stigmatizing and more pathologizing. And calling it as illness, once again, according to in all standard, illness is something which should impair the quality of life of an individual. If at all we take the gender dysphoria patients who have undergone transition and they are living in they are more often they are happy with their identity, and they are more distress. Their distress comes from the social rejection of their identity rather than with their identity themselves. So can we call it as illness? My answer will be no. So then what can we call it? What can we call it as? It is a variation. It is a variation in nature which needs to be accepted as such, and we need to help them come across with a non-judgmental attitude and to navigate the issues. So Finally, I need to end with this only with one point. It is their body and their choice. We as a society cannot regulate one's body, and doing so pulls us back decades. So, finally, I end up my presentation thanking with my professors Dr. J.V. sir and Dr. Ilangovan sir and my mentor Kasi Krishnaraja sir for helping me come up here, and all of you for your patient listening. Thank you.
Thank you, Dr. Avudayappan. It was a quite interesting and nice deliberations with regard to gender dysphoric disorder. It's clearly explained about the concepts of transgender, gender dysphoria, intersex, gender identity disorder, disorder of sexual orientation. All these things he has clearly explained. Transgender is entirely different from gender dysphoric disorder because dysphoria is not necessarily present in the transgenders. And we are very much worried about the comorbid psychiatric conditions like anxiety and depression and suicidal attempts and ideas they develop in the gender dysphoric disorder. We are, as a psychiatrist, we are not supposed to realigning the sex, assigned sex as well as the perceived sex. So our aim is to reduce the distress and the stigma of the gender dysphoric disorder. Actually, the sex change operation or the transitional operations and the hormonal therapy are doing harm than good for the gender dysphoric disorders. I would like to add points to this.
Thank you, sir. And thank you, Avudayappan, for bringing up and enlightening a lot of phenomenological changes and terminological changes of dysphoria starting from DSM and ICD-10 and all the three concepts of the biologics theory, cute therapy, and the social characteristics. As our co-chairperson has told that the associated comorbid conditions can alone be treated rather than considering the treatment of their own choices of picking up their sex alliance. And I think it is a very difficult part for the psychiatrist to manage in a routine clinical practice because we lose follow-up over a period of time, and it is very difficult to hold up for the patients like that. And most of the time it is only cross-sectionally analyzed, and we are just giving some medication for a few days, and there too they not continue the medications due to the effect of the side effects, thinking that there will be some other problem. So I think so. This is more of theoretical knowledge which has put into a practical knowledge as a presentation, and I would like to thank Dr. Avudayappan for bringing in a good insight about this concept of gender dysphoria. And this session is open for questions to the
Good morning. I am Dr. Ganesh Kumar from Madurai. I have a question to ask you. Is there any age where this particular dysphoric features start to manifest? At what age? If at all, if it happens, will the puberty will worsen the condition? Because I have come to know only the puberty will, at the time of puberty, the disease starts to happen. And second thing is that in the school, do we need to have any sensitization program for the faculty and the management with regard to this particular gender dysphoria? Because most of the children are getting humiliated and embarrassed, sometimes made fun. So all these things are happening. Sometimes we find it very difficult to handle since I've been associating schools. Your answer, please. Thank you.
Sir, you asked a very controversial question. Actually, this is a heart of controversy which is going on in America right now. So, Western countries right now. Sir, basically, gender dysphoria is considered to have started in a childhood as well. So, the age at which gender dysphoria starts is a matter of controversy. For a few people, especially in gender activists, the gender dysphoria starts as early as 4 years of age. And they tend to identify themselves as their gender and non-gender. That at that point itself, gender dysphoria starts. But in our clinical practice, when we ask them at what point you started to realize gender dysphoria, mostly in our people, we come up that the most frequent answer is 8 to 10 years of age. So even pre-puberty, they have recognized that they are not having a gender which is not congruent with their assigned sex. So whether this puberty worsens the condition, definitely there is a patient who is having a real gender dysphoria, the puberty worsens the condition. But But then it gives rise to another question whether we need to suppress the puberty or not. It's a very controversial topic, and still the guidelines as such has not suggested any suppression of it. But there is a model of treatment called Dutch model, where we have people who have advocated gonadal suppression in the prepubertal stages. So what is the problem with that is there is a concept of desisters. These desisters, they are the ones who have identified themselves as having gender dysphoria at an early age, but later point of their time, they say that they no longer have gender dysphoria and they want to conform to their assigned sex. So these desisters, how much are they, what is their proportion, and how much they are, we need to know about that, but there is no such data which is available. And being a very much hotly debated topic with so much of activism around it, it is very difficult to collect this data without any bias. So that is another thing, sir. Regarding your second part of the question, whether we need to have a sensitization program in the school, yes sir, definitely we can have sensitization program. But the social acceptance is the problem. So because people, the common belief or myth they have is talking about gender dysphoria or introducing the idea of gender dysphoria, then individual will start to transition into transgender. Just because we had a talk, they listen to that, they would transition to a transgender. But that is not actually so. If we remember that model, the awareness starts first, and then they seek up questions about themselves, and then they seek out whether they are having anything related conditions, and that point when they come to know about transgenderism, they accept that. But it is very difficult to convince people otherwise. So we need to bring more awareness about awareness and acceptance about gender dysphoric condition, and then only at that point we can bring that into the school curriculum, sir. At the present, it is the resistance by the society which is the problem. Once we can come out of it, then definitely we can include that, sir.
Good evening, all. It was an excellent presentation by Dr. Avadayappan. As opening batsman, he has started our program in a very excellent fashion. Just as a government hospital with gender reassessment surgery procedure being done, is the second hospital in the state is our Madurai Medical College next to Chennai. And we faced a lot of problems in the past 1 year. Our department is involved and there are confusing guidelines. My question to you is, how many cases after gender reassessment surgery want to revert back to the previous condition? Whether have you come across anything? Because I know that was such, because your choice was unanimous, because when I came to Mahatma Gandhi 6 years ago, you had shown me that you are running a transgender clinic on Tuesday or Thursday, I think Tuesday. I was very much surprised. That reminded me when we were discussing about this topic to call you. Have you come across any patient who has undergone surgery trying to or expressing his wish to return back to normal? Any such thing? And also please suggest how to tackle the surgeons, because they are totally unaware about anything of what we are discussing. Just since insurance scheme also covers this surgery, they are very much eager to do whatever they like. So they want consent from us. So it is a problem for us. It's a definite problem for us. We are keeping it low profile without informing anybody. You have to highlight that. Thank you.
To answer the first question, sir, we think we have seen around and we have performed around 600 SRS surgeries in the last 8 years. I think I don't know the exact number, it's around 600, sir. And we have not yet seen one person who has expressed regret about the transition. One thing I need to give up here, I need to tell here is most of our clientele, as I told you, they come from a transgender community. So they have already transitioned with other methods. So SRS is the final stage. So that may be one thing. But even otherwise, where we have had experience with other clients who are not from the transgender community, even otherwise they are also not expressed any and literature wise, the regret, post transition regret usually is centering around two things, sir. One thing is because of their the transition experience. When there is a poor transition experience where they have to go to multiple places, where they are ridiculed for their appearance, and there lot of delay to get the consent, that process makes up a very much morbid thing, sir. That is one thing is cause for regret, post-operative regret. Another thing is that the end result of the surgery, if it doesn't turn up as what they expect, then that is the cause for cigarettes, sir. So that is why we have developed this model where the first stage we confirm the diagnosis, then we send them to the surgeon, and surgeon confirms what is the procedure, and they show them the slides that this is how your genitalia will be at the end of the surgery. Don't have more hopes. Your clitoris will be removed. You will not have this genitalia will not be functional for sexual pleasure. This cannot be used for your other. So all this we need. They are explained, and then the need to have, suppose a person wants vaginoplasty, then they need to adhere to a constant dilatation. Those procedures are all they have to follow. So all that is explained to them, sir. So that part, once they conduct that, then they are more knowledgeable about the surgery and what to expect from that. So that is why I feel that the regret part is much less. So they come to us knowing what is in store, sir. Regarding the second part, yes, sir, when we had the initial things, it was very difficult to convince surgeons to send us prior to that. Most often, how the referral will be is, the referral will come at 3 o'clock in the evening, and our hospital ends at 4 o'clock. They will ask us, please give us consent for this patient. Then we ask them what time the surgery is, they will tell that it is at tomorrow morning 7 o'clock. So how can I assess within 1 hour and then do that? So what we did was, we have a gender committee in our hospital. We represented to them, and we had an activist in that gender committee also. So it was very easy for us to represent that. And as a hospital policy, we developed an SOP that this should be the thing. This day they should attend psychiatric PD. This day they should attend So having seen the surgeon, if they come back on the same day, we won't see the patient. We will send them to the next week. So these are the things which we follow strictly. So the SOP, once it is followed strictly, it has become a practice. So now there is not much of an issue, because something has been set in motion and it is going on. So that is how I would suggest you, sir. So you can set up a committee in hospital level, and then have in that committee we can include a surgeon, medicine, dermatologist, pediatrician, all those things, gynecologist, all those things, and a plastic surgeon, and then we can formulate the guidelines, sir. That is one thing which we can do. Sir.
Yes. Good afternoon. You made a very lucid presentation about this particular topic. You made a right point that it is not a myth, it's not an illness, it's one's experience about his gender. I think first topic given to this area is, I think, a welcome move from Tamil Nadu IPS. I think this is not falling in main curriculum of MD psychiatry training. Rightly, that is currently I am working with Rajiv Gandhi Government Hospital, where transgender board is regularly meeting once in a week, and there are a lot of funds being allotted for this particular area, that is welfare of transgenders, in which there were expert committee formed, in which we happened to come across a committee insisting on IQ assessment. I had gone through guidelines, especially WPATH you mentioned, subsequently the Transgender Rights Protection Act 2019. Nothing says about IQ assessment. Unfortunately, few people, the budding psychiatrists, they are very rigid about following this particular expert committee's opinion, which is communicated through a IAS officer.
Yes, sir.
So even they consider it is a GO. Then later on explaining, and we need to follow the act is superior to the expert committee's opinion. We gradually shifting to restricting the visits of transgender to 1 or 2 visits.
Yes, sir.
And do you have any idea that any particular guideline asking for IQ?
No, sir. The presence of mental health comorbidities itself is not considered as a contraindication for sex reassignment surgery, sir. So even if a person with transgender, if it's gender dysphoria, they have psychosis, the only criteria is that it should be treated and it should be under control. and they have to undergo the search, they can operate on that. So having an IQ test for a transgender who's at 30 years or 40 years of age, who has managed to do activities of daily life and their ability to manage that, I think that is stigmatizing, sir.
I think here we more act as a mental health professional who looks for any comorbidity or implication of mental health on decision making.
Yes, sir. So in that case, that is where that model we follow, I mentioned, sir. We have a assessment for mental health comorbidities, but that is a clinical assessment. We don't involve the psychological assessment there, sir. That way the length of the visit and then the necessity to have multiple consultation, that gets cut short. So clinically, if there is no IQ problem, clinically if I can assess the IQ to be normal, that is all right, sir. Why we need to have a psychologist to stamp to that? So, and again, similarly for there are certain rating scales for this gender dysphoria, Albright rating scales and other things. But eventually those things are tend to confirm what is going to be, we are going to see in clinical scenario. So why we need a thing to tell it is gender dysphoria? That is why we we restricted to the screening by clinical terms and then going on with this process.
After listening to your lecture, I understand that you have rich experience in seeing people with this transgender experiences.
Yes,
Do you have any idea to take it forward? That is, we need more insights in this area.
Actually, sir, we have been consulted by central government Secretary of State, sir. But their consultations are mostly about the finance part, how much to give, whether to put this under a cosmetic surgery or whether to put it as a treatment process. Those are the things they are more worried about financial
Excuse me,
parts.
sir. Sorry to interrupt.
Yes, sir.
As we are running short of time, we now request the members of the floor to keep short with the questions.
Yes.
Thank you.
Actually, I came across a court case where a patient of gender dysphoria was given ECT and also drug therapy. And the judge has condemned this procedure in the open court. And I don't know the final outcome of the judgment, whether any compensation was levied, because the affected parties have gone to the court and the judge has given this verdict. So it is a high time. We have to formulate certain guidelines. Already there are IPS guidelines, practice guidelines for several disorders, for OCD, substance abuse, all those things. Now that our IPS president is also here, I think it should be a job of our IPS to formulate certain guidelines so that it will be protective to the psychiatrist, at least in India.
Definitely, sir.
To what extent we can treat, what type of pharmacotherapies we can give, up to what extent, what are the symptoms for which we have to handle, and what are the do's and don'ts, what are the things what are the treatment strategies that we should avoid in certain cases. So like that, if we formulate certain guidelines which is applicable throughout India by our recognized body, such court cases can be withstood by the affected psychiatrist.
Definitely. Sir, actually, the thing is that in the treatment is given for the purpose of conversion from one gender to another to prevent gender dysphoria, then that is considered to be problematic, sir. So other things.
Just one
Kind
question.
attention. So let this be the last question.
I request
Sorry to
this
interrupt.
could be the last question in the session.
To the extent to Professor Panudurai's question, is anything called secondary gender dysphoria? Because in my practice, I came across 3 patients. One patient, a 16 years old boy, came with gender dysphoria. When I went through the history, his father had similar symptoms at the age of 16 years. It was transient and disappeared over the period of time. And again, the boy's grandfather also had similar symptoms. In another case, a bipolar mood disorder with a family history of Wilson's disease, that person, a male, whenever he gets manic episode, he developed gender dysphoria. And another, a girl, 15 years old girl, she had gender dysphoria. Even she wrote a love letter to her own gender, and she felt that she was having opposite gender. Then I explained the parents that you have to accept. Then that girl went to another psychiatrist, and she was treated with antipsychotics and antidepressants, and she became normal. That gender dysphoria disappeared. So, is there anything called secondary gender dysphoria? should we evaluate before considering a primary gender dysphoria?
Yes,
That's
sir.
it.
Actually, disease process presenting as gender dysphoria is well known, sir. Even I have seen one case of bipolar disorder with who's presenting with GD symptoms only at mating phase. But one thing we need to be very sure is that we are not missing out real gender dysphoria which is prevalent there, sir. So we need to distinguish between illness behavior as well as with the real developmental process that comes with the clinical workup, sir.
With these questions, we would like to end the session and thank the organizing committee for requesting us to chair the session. Thank you. Thank you all.
Thank you, sir, for such an enlightening session about gender dysphoric disorder. I now call upon Dr. Ganesh Kumar, sir, to honor the chairperson, Dr. Ashok Kumar, sir. I now call upon Dr. Arun Prasna, sir, to honor our chairperson, Dr. V.K. Arvind, sir. Thank you, sir. I now call upon Dr. V.K. Arvind, sir, to honor our speaker, Dr. Avudaipan, sir.
With this, thank you, sir. With this, we shall move on to the inaugural ceremony.
So much discussion.
Honor. H is silent. Honor. We shall now move on to. Hello. Yes? Sorry, ma'am. Please call me later on. We shall now move on to the inaugural ceremony. கொஞ்சம் இதானதுக்கப்புறம் கொஞ்சம் Come on, let's start. We shall now move on to the inaugural ceremony.
I now call upon our chief guest, Dr. N. Raju sir, over to the dais. I shall request our Tamil Nadu IPS President, Dr. Kumaran sir, over to the dais. May I request our Tamil Nadu IPS President-elect, Dr. Malayappan sir, over to the dais. I shall now call over to the dais our Tamil Nadu IPS Secretary, Dr. Siva Ilango sir. I shall now call our Tamil Nadu IPS Treasurer, Dr. Sivasailam sir, over to the dais. May I request our Tamil Nadu IPS Editor, Dr. Srinivasan sir, over to the dais. May I request our Tamil Nadu IPS South Zone Representative, Dr. Paniselvam sir, over to the dais. I now request our organizing president, Dr. Ananta Krishna Kumar sir, over to the dais. I shall now call our organizing secretary, Dr. Sabrin Ross sir, onto the dais. Shall I request our organizing vice chairman, Dr. Vishwanathan sir, onto the dais? We shall now start with Tamil Thai Valtu.
நீராறும் கடலுடுத்த நிலமடந்தை கெழிலொழுகும் சீராரும் வதனமென திகழ்பரத கண்டமிதில் தெக்கணமும் அதில் சிறந்த திராவிடனல் திருநாடும் தக்க சிறு பிறை நுதலும் தரித்தனரும் திலகமுமே அத்திலக வாசனை போல் அனைத்துலகும் இன்பமுற எத்திசையும் புகழ் மணக்க இருந்த பெரும் தமிழனங்கே தமிழனங்கே உன் சீரிழமை திறம் வியந்து செயல் மறந்து வாழ்த்துதுமே வாழ்த்துதுமே வாழ்த்துதுமே.
Thank you, everyone. Now, the welcome address will be given by our organizing president, Dr. Ananta Krishna Kumar sir.
respected National President of IPS and Chief Guest of the function, Professor N. Raju sir, respected Tamil Nadu State President, Professor Kumaran sir, respected Tamil Nadu State President-elect, Professor Malapan sir, Tamil Nadu IPS Secretary, Dr. Sivailango sir, Treasurer, Dr. Sivasailam sir, Editor, Dr. Srinivasan sir, South Zone Representative, Dr. Pannirselvam sir, Senior Professors, delegates from all over the state and also Union Territory of Pondicherry, respected my senior professors, family members, postgraduate students, undergraduate students, former executives and representatives, ladies and gentlemen, good afternoon to all of you. On behalf of organizing committee and the Indian Psychiatric Society Madurai chapter, I welcome you all for the 33rd Annual State Conference of Indian Psychiatric Society Tamil Nadu branch. Our special thanks to National President who has kindly accepted and being a chief guest in spite of his busy schedule. So we have an exciting scientific sessions, academic sessions, as well as presentations, free papers, award papers, apart from undergraduate and postgraduate quiz. So for this, we are going to have a academic feast for the next 3 days. So once again, I welcome you all. Thank you very much.
We shall now have the ceremony of lighting a Kuthuvilakku.
Now it's time to honor the dignitaries on the dais. First, our chief guest, Dr. N. Raju sir, will be honored by TNIPS President Dr. Kumanan sir. Now, may I request Dr. Kumanan sir to honor Dr. N. Raju sir with shawl and sandal garland. Thank you, sir. Now, our TA. Now, the TNIPS President, Dr. T. Kumanan sir, will be honored by Organizing President, Dr. Ananda Krishna Kumar sir. May I request Dr. Ananda Krishna Kumar sir to honor the TNIPS President, Kumanan sir. Now, the TNIPS President, Dr. Malayapan sir, will be honored by Organizing Vice Chairman, Dr. Vishnadhan sir. May I request Dr. Vishnadhan sir to honor the President-elect, Dr. Malayapan sir. Next, TNIPS President, TNIPS Secretary, Dr. Shive Lango sir, will be honored by Organizing Secretary, Dr. Sabrin sir. May I request Sabrin sir to honor Dr. Shive Lango sir. The next TNIPS Treasurer, Dr. Shivasailam sir, will be honored by Organizing President, Dr. Ananda Krishna Kumar sir. May I request Ananda Krishna Kumar sir to honor Dr. Shivasailam sir. Next, TNIPS Editor, Dr. Srinivasan sir, will be honored by Organizing Vice Chairman, Dr. Vishwanathan sir. May I request Vishwanathan sir to honor Dr. Srinivasan sir. Next, South Zone Representative Dr. Paneerselvam sir will be honored by Organizing Secretary Dr. Sabrin sir. May I request Sabrin sir to honor by Dr. Paneerselvam sir. Now, the Organizing President Dr. Ananda Krishna Kumar sir will be honored by our Chief Guest Dr. N.N. Raju sir. May I request N.N. Raju sir to honor Dr. Ananda Krishna Kumar sir. Next, the Organizing Vice Chairman Dr. Vishwanathan sir will be honored by TNIPS President Dr. Kumanan sir. May I request Kumanan sir to honor Vishwanathan sir. The Organizing Secretary Dr. Sabrin sir will be honored by President-elect Dr. Malayapan sir. May I request Malayapan sir to honor Dr. Sabrin sir.
Thank you, everyone. I now call upon our Tamil Nadu IPS President, Dr. Kumanan sir, to preside over our inaugural function.
Good evening, all. First of all, I express my sincere gratitude to all who have attended to this 37th National State Annual Conference run in a physical mode after a period of 2 years. Even though Mahabalipuram had a physical conference, that time the COVID fear was very severe, and this time COVID is playing hide and seek with us. Even with this threat, many have braved to attend this function. I first of all extend my sincere thanks to all. This twin function, I have to preside and I have to step down as a incumbent president, and I have to pave the way for a president-elect Dr. Malayappan. And at this juncture, I am very happy that I was the organizing secretary of the last conference held here by the IPS Madurai chapter 11 years ago at the same venue. I was the organizing secretary, and I could see a lot of new faces and a lot of new psychiatrists, evolved psychiatrists. I am very happy, and the interest has increased much among us regarding the attending the scientific sessions, and scientific sessions are well crafted. I know on February 27th, myself with the organizing secretary and the vice chairman, we came here to find out the location. On the way, just at the foothills, the car battery got burst. It was in flames, so it has to be doused. I thought that is not a good signal, but we didn't give up, and we started walking towards the downside for about a kilometer, and then the driver took the vehicle. He got it all right. The battery problem was solved, and we traveled back once again. We came here on February 27th. That was the first day. We came here. We searched for all locations. Finally, we finalized here, and after that, the organizing team was very active. Every week they arranged for meeting, tele-meetings, everything, and they finally made it as a possible, which I thought was a dream, and I'm very happy that it has culminated in a very happy end. Our Tamil Nadu Psychiatric Society just needs a gentle nudge, as rightly pointed out by our National President Raju Garu Sahab. When he talked on Tanjavur CME, he was little upset that our presence was very little. Only the speakers and the office bearers were there at the CME. Other state people were there. So he said, with a lot of members, you have to show your presence. And I think this message has been well conveyed to all our society members. That may be the reason that a lot of people are here, and very happy. And with these very few words, extending my heartfelt thanks to the organizing team, the untiring team consisting of Dr. Anand Krishna Kumar, Dr. Ramanujam, Dr. Sabrin, Dr. Ganesh Kumar, Dr. Viswanathan and others, Dr. Bhagyashree, Dr. Sugadev, Dr. Preeti, lot of, and even Dr. Ravi Kumar did in the back end. So lot of people participated in the organizing this successful event, and I'm very happy this is going on a very smooth fashion, and nature is also helping us. It's very difficult to organize a conference at a hill station where there are no facilities, and in this COVID period as well as this rainy season, rains may come anytime. So to make a makeshift tent, they spent a lot of time discussing the arrangements, and finally it appears as if we are in a very pakka established concrete building. So thanks to the organizing team once again. With these few words, I welcome Dr. Malayappan, President-elect, to become a President and take over the session hereafter, and with congratulating him for his new tenure. See, these 2 years has been a very troublesome period for all of us, and I expect a good future for all of us in social as well as physical as well as in other economical aspects. With these few words, I hand over this medallion to Dr. Malayappan, this installation of new office bearer.
Thank you, sir. May I now call upon Dr. Malayappan, sir, Indian Psychiatric Society Tamil Nadu President-elect, to felicitate the event.
Respected Chief Guest and National President of IPS, Professor Dr. N. Raju sir, respected President Tamil Nadu IPS, Tamil Nadu chapter of IPS, Professor Kumanan, and respected Secretary Tamil Nadu chapter of IPS, and the dignitaries in the dais, on the dais and off the dais. I'm extremely happy to be in this conference, 37th annual conference of Tamil Nadu chapter of Indian Psychiatric Society. And as per the schedule, today and tomorrow, Dr. President Kumanan sir will be the president, and I have to take over as president only on Sunday morning as per the schedule. But Professor Kumanan has some family events, and so he has made slight modifications, and I agree for that. And it is a very nice place, Kodaikanal, and a very nice team, organizing team, with very nice topics selected for CME and other academic sessions, and very nicely organized conference. And I wish the conference all the success, and thank you. Thank you.
Thank you, sir. I now call upon Dr. Shiva Ilango, sir, IPSTN Secretary, to felicitate the event.
Very good evening to all of you. Respected President, Indian Psychiatric Society, Dr. N. Raju sir, respected office bearers of TNIPS, respected members of the organizing committee, TANPSYCON 2022, Kodaikanal. It's a great pleasure to be here addressing this crowd. This is the first conference I'm being part of as taking over as a secretary since last year. So for me, the 37th conference being held in Kodaikanal is a lot of memories and experience of working along with the organizing committee members how to conduct a conference. Moreover, from the previous year, being myself as one of the joint organizing secretary, the conference held in Radisson Blu in Mahabalipuram, we know how difficult it is. At one point, Dr. Anandan and myself have decided that it's going to be a lot of difficult challenges, so we had to seek the help of event management company at the time. But here in Madurai, this team, when they took over, when they volunteered to conduct this organizing the conference last year, but mainly for giving a big hand for Dr. Kumanan sir being as a president. So the plan was to conduct mainly in Madurai. But then when the IPSOCON was in Madurai, they felt like, no, we are not going to do it again in Madurai. So we want to find another venue where we can attract a lot of crowd. And they choose this place. And again, like Sir Kumanan said, it's not that easy to host a conference in Hill Station. And being that organizing committee members, all of them back in Madurai. And they did a great job. And like Sir said, 6 months they've been conducting meetings. There's a lot of planning involved, excellent delegation and coordination between the organizing committee members. And you can see the title itself. There's a rhyming title. They have put a lot of thoughts through about pearls and perils in psychiatry as a theme, and they handpicked the topics in terms of being it a gender dysphoric disorder or understanding adolescent suicide, or even the panel discussion that's going to happen tomorrow. So there's a lot of things that I have really thought about it, and for the benefit of the practitioners. And it's something like, being in Kodaikanal, children have a lot of fun, families, a lot of, sightseeing. And in addition to that, for the practitioners and the postgraduates, there is something for everyone, if not everything for someone. So let us all learn and enjoy the feast, the hospitality shown by the organizing committee members. I welcome you all. Thank you.
Thank you, sir. I may now call upon Dr. Shivasailam, sir, Indian Psychiatric Society Tamil Nadu Treasurer, to felicitate the event.
A warm good evening to all of you. Respected Chief Guest Dr. N. Raju, sir, respected professors, office bearers, and my dear friends. So first of all, I want to congratulate Madurai Association of Psychiatrists for arranging such a wonderful venue here. I was in touch with Dr. Sabrin for the last 3 months. I know he came how many times I know. That is, he came here for more than, I think, 8-9 times here, I think. 5 times, yeah. So I thank this opportunity to welcome you all. And from TNIPS, we are releasing a smart card today. And our chief guest is going to release the smart card. And our IPS president, TNIPS president, is going to receive it. So I once again thank the entire team of Madurai Association of Psychiatrists for arranging such a wonderful venue. Thank you so much.
I now request our IPS Tamil Nadu President, Professor Dr. T. Kumanan sir, to hand out the souvenir to Chief Guest, IPS President Dr. N. Raju sir.
The souvenir will be jointly released by the IPS President and Tamil Nadu President.
We now request our chief guest, Dr. N. Raju sir, to release the souvenir to everyone in the dais. We now request our chief guest, Dr. N. Raju sir, to release the IPS, to release the smart card to our Tamil Nadu President, Dr. T. Kumanan sir, and also others. Thank you, sir. We now request our chief guest, IPS President Dr. N. Raju sir, to address the gathering.
The President of the function and the President of Tamil Nadu branch of Indian Psychiatric Society, Dr. Maniappan, then the just now outgoing President, Dr. Kumanan, rest of my friends on the dais, seniors, friends in the audience. It's always a pleasure to participate in any meeting organized by the IPS Tamil Nadu branch. I would say that I have been pretty lucky, very fortunate to have friends in every corner of this state. In fact, I owe my growth to the many greats that Tamil Nadu branch had produced, and many, many friends, especially in Madurai. I'm sure I have many, many in Madurai, who have been literally, I would say, force behind whatever I have achieved in Indian Psychiatric Society. In the audience, we see literally the people whom we all have adored. We all have seen them as our somebody one day. Can we be like them? I can see Dr. Nambi, Dr. Ponudurai, Dr. Shanti Nambi, Dr. Sachinathan. I think in spite of their extremely good achievements, they have considered all of us as equal. They have been quite friendly and has always been. I think we had even took the liberty of cutting jokes or pulling the legs with them, though they are very, very seniors. Especially, I think if you see Dr. Satyanathan, I think he's like my teacher. But still, we enjoy, a joke here and joke there. I think this is something which I have learned from this beautiful crowd. When I see there are inviting me, especially today, because I have to attend another meeting tomorrow. So they have, readjusted their entire program to see to it that I am here. I think that is what I see as the perils in psychiatry. The rest are all pearls. The perils are like accommodating the leaders and making them listen, talk and all. I think these are, otherwise I see everything pearls in psychiatry, more so in Tamil Nadu branch. As Dr. Kumaran was telling, I think it is high time that we all sit together and do something about putting the members on the national platform, which unfortunately is missing now. Earlier, as I repeatedly say, I am not sick of saying that year after year, the presidents are from Tamil Nadu. Every time, I think Tamil Nadu has been in the forefront as far as ANSIPSA is concerned. If you see now, no one really, at least I know that the problems of reaching the top is not easy, but it is not difficult either. So what I request, once again, this I think I'm not sick of repeating this again. Maybe, especially after having listened to the talk just before the inauguration, that was so brilliant, so good. I think such things should be there on the national platform. So to do that, I think either you do a lot of good research work or do a lot of society work. Both are unfortunately are missing. I think we need to do that. I request people, especially on the dais, I see everybody quite enthusiastic. My friends are quite energetically doing it, especially when you see the way in which the entire conference is being organized here. This is a lawn earlier, if I can remember this, and they have converted into almost like a 5-star conference hall. I think the amount of hard work that must have gone behind this is quite there to see to us. So my only humble request to everyone is that we need to, I think, inculcate that earlier, that character and driving, internal energy to see to it that our younger generation come forward, make a mark both at the national level in the IPS and also at the academic level, because we have, I think, one of the states where we have a lot of good departments in Tamil Nadu, many medical colleges in and around Chennai. I'm sure we should be able to produce some good research work, which will again bring us laurels to the state. So, as I said, it has always been a pleasure and honor to be here. And also the topic we have chosen was pearls and perils in psychiatry. As I said, I don't see any perils at all. I see all perils. So because this is one exciting branch where we all enjoy, knowing about it, and also the advances that are occurring in psychiatry are more and more interesting, and more and more, even though the biological aspects are coming in, again, more and more things are being discovered or invented, and more applications are being done as far as the knowledge of psychiatry is concerned. And I hope that our brethren in Indian Psychiatric Society Tamil Nadu branch will work hard to see to it that few names are there at the national level, both academically and also from the society point of view. So this is, I think, I don't mind. As I said, this is one thing which always be at the both at the back and front of my mind. Hopefully, we will work with Dr. Aravind and Dr. Kumanan, Dr. Everybody. So finally, we need some people who represent, I think, at the both, as I said, another aspect which I really enjoyed here is the Kodai Canal itself. This is one place where I think everybody enjoys it. Weather is fun. You don't believe that you are in South India. It is something that you are, I think it could beat any country, in any place in the world. Such a nice place, such a nice weather. I had the occasion of going around the city with such a beautiful lake in the center of the town. And I'm once again thank the organizers for choosing a place like this to organize, which is not an easy job. It speaks volumes and volumes and volumes of their hard work, their dedication, and their, I think, unending energy to make this conference a success. And I already see a lot of success in this conference. A conference well begun is half the job done, and I'm sure the another 2 days are going to be very, very fruitful, both academically and also the pleasures of being together. This is the first conference, I believe, after the COVID has erupted. So I'm sure all of us would enjoy that. Unfortunately, again, I would not have the pleasure of spending all 2-3 days here. I had to rush back to Tirupati to take part in IPS AP chapters conference. So I wish this program a grand success, and once again I thank every one of you for giving me this opportunity of standing before you and inviting me as the chief guest of this evening. And once again I repeat, Tamil Nadu is one branch. We look even in recent problems also, the first people whom we call would be either Dr. Nambi or Dr. Ponudurai to see this is the problem, especially there is a court case, there is a legal problem or something. They're always there for us to support us, because we are running IPS with their blessings, with their guidance. And I'm happy that I'm here, and I'm happy to see Dr. Raghotaman, Dr. Ashokan in the audience. I'm really happy that I could get connected once again to the friends. I don't call them old friends. They're all young, and we continue to have the friendship, and I wish this camaraderie, and I again request them to see to it that they, I think, once again create a pool of youngsters who would work hard to see to it that Tamil Nadu is once again on the top, as it was maybe about a decade back. So once again, thank you all for giving me this opportunity. Wish everybody success. Thank you so much.
Thank you, sir. I now request our organizing secretary, Dr. Sabrin Ross, sir, to deliver the vote of thanks.
Thank you. There's a small mishap. I now request the memento is handed over to our chief guest and others. To the chief guest, our organizing president will hand over the memento to our chief guest, Dr. N. Raju. Our organizing vice chairman will hand over to our TNIPS president, Dr. Kumanan. I request our organizing vice chairman, Dr. Vishwanath, to hand over memento to our IPS secretary. I request Dr. Sukhdev to come on stage to hand over the remaining mementos. to our treasurer, to our editor, and IPS South Zone representative, Dr. Pannirselvam. Apologies for this mix-up. Moving on to the last part of the inaugural function, vote of thanks. Good evening, my dear friends and dignitaries on stage and off stage. This has been a journey that we started maybe a year ago at Mahabalipuram, and speed picked up somewhere in probably December, January through online meets, and then as our president saying, it picked up. And one of the reasons, the main reasons for taking up this conference was to honor our president, or immediate past president, Professor Dr. Kumanan. As you all know, he's been the HOD and professor for more than 5-10 years. And I think many students who are passed from South India would have faced him as an examiner. So he's a wonderful teacher and examiner. So to honor him, we kind of volunteered to do this. So that is probably one of the main reasons why we took up this conference. And then we wanted to, the whole organizing team, we wanted to talk about topics that come up when a patient walks into our consultation room. Nothing academic, nothing hi-fi, just simple things that we have to face in everyday life, which we are probably stuck for answers. And we had a great team that went through the topics and picked it up. And then the next thing that we wanted to was give opportunities to young psychiatrists and lady doctors. So we tried our best to get speakers and with that criteria. And without forgetting, I should thank IPS Tamil Nadu branch for trusting us with all this and supporting us all the way through. And if I have to name all the members in the team who worked hard for this, I think it will take a very long time to thank them and do justice. So I thank the whole team for being with us, and I'm just a face behind this team that made this happen. And as my friend always says, keep it short and sweet. I hope you have done that so far. So thank you. Please enjoy the academic feast and the hospitality and Kodai. And hotel has been doing a great job for us. So thank the hotel also, and everybody, former friends, everybody has all helped us out in crucial stages of audio visual, our fabrication, everything has done a great job. So thank you. Please enjoy it. Thank you.
Thank you, sir. I request everyone to rise up for a national anthem.
जनगण मन गदिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उत्कल जलधि तरंगा
We shall now start with the next session by Dr. T.V. Asokan, sir. The session is on practice guidelines, science subverting art. The session will be chaired by Dr. Bhaskar, sir, and Dr. P.P. Kannan, sir. May I request Dr. Bhaskar, sir, and P.P. Kannan, sir, to come on the dais. Dr. Bhaskar, sir, is a professor and HOD of Vinayaka Mission Medical College and is a consultant psychiatrist in Salem. Dr. P.P. Kannan, sir, is a professor of psychiatry in Madras Medical College. He is a chairman of Research Capacity Building Committee of IPS Tamil Nadu. May I request the chairpersons to introduce the speaker?
Good evening, everyone. We are having a wonderful evening in Kodaikanal with the hospitality of the Madurai chapter hosting this TANPSYCON. And I am overwhelmed and proud and subdued to introduce my teacher, Dr. T.V. Ashokan. He is a professor and HOD at Sri Muthukumaran Medical College, and he has more than 32 years of teaching experience. And I personally know him for more than 40 years in different places. And he has authored chapters in textbook of psychiatry and 3 books in mental health in Tamil also. And apart from all these things, he is a good calligraphy writer, which is not here. I think everybody can read whatever he is in the slide, but apart from that, he is a very fantastic calligraphy writer. He has all the pens and a wonderful collection of locks. And he is the right person to talk about the art of psychiatry, because as a teacher we saw him, the elicitation of the symptom, how to communicate with the patients. The art of psychiatry we learned from these teachers. They are simply marvelous. And how this art is going to getting subdued, or they had a jargon called as subverting. The science is subverting the art. Let us watch our Dr. T.V. Ashokan, how he is going to unveil the myth. Over to you, sir.
Respected President of Tamil Nadu IPS, Professor Malayappan, respected President of the National IPS, Professor N. Raju, respected Chairpersons, Professor Bhaskar, Professor P.P. Kannan, Executive Committee members of Tamil Nadu IPS, senior colleagues, friends, ladies and gentlemen. It's indeed a great pleasure to be here to deliver a lecture on this topic, Practice Guidelines, Science Subverting Art. I'm going to approach this particular topic in 3 different parts. The first part, I'm going to really clarify what is science and what is art, and where psychiatry is, whether it is juxtaposed between science and psychiatry. And the second part, unless until we know the conceptualization and compilations of the clinical guidelines, I don't think we'll be in a position to comment whether it is really advantageous to psychiatric profession or it's going to be a fly in the ointment. Of course, my third part would be critical appraisal. What medicine is, what helps or heals. In a lighter vein, there is an aphorism called doctors, they don't cure illness, they just postpone death. What is science? Understanding something is a science. Becoming aware of something is science. Knowing about something is science. Whereas art, implementing what you really acquired in the therapeutic milieu, doing is art. Science discovers, but art creates. Some people consider psychiatry as an art, some construe as a science, some emphasize that it is both science and art. Scientific truth in psychiatry, most of the scientific truths are born out of serendipities. The half-life of scientific truths are very short-lived. What is considered as a scientific truth in psychiatry, tomorrow it may become folly. On and off we come across certain incidents that doctors are abused, ridiculed and manhandled, not for not knowing the science, but not for really practicing the way they are expected to. At an individual level, what exactly is happening between a doctor and a patient is a trust. Trust is the main factor. Psychiatric patients or the general population, they believe that high-tech science would offer a solution for anything and everything, but unfortunately during emergency situation, it is the art of psychiatry that rules the roost. To practice psychiatry, to master the art of practicing psychiatry, one has to be compassionate. Otherwise, it is very difficult to be a psychiatrist. We'll be like a salesman in a pharmacy, just dispensing medicine over the counter. One has to be communicative. Communication is an important factor. Pretty well other specialties are different. Psychiatry is based on subjective interpretation of an individual. It is a speciality of uncertainty. When I say communication, it is a process that some information is disseminated from one communicator, another person is receiving. It is not only just communicating, it is also listening. Here I would like to emphasize there should be some kind of a difference between hearing and listening. What we really employ with the spouses, that is a hearing. Just perceiving an audible format. Listening, understanding the meaning of the audible format. To be an effective communicator, one should talk in such a way that others are interested in listening, and listen in such a way that others are interested in talking to you. And more than that, empathy. That is very important. Empathy is nothing but a kind of an emotional experience to understand the agonizing experience of the patient from the perspective of the patient. Majnu was saying Laila was the most beautiful girl. Somebody retorted, no, Laila was just ordinary, below average. To this Majnu retorted, get into the shoes of Majnu and see through the eyes of Majnu, Laila would be appearing beautiful. Imagine a person is coming to psychiatric OP and complaining of phobic anxiety features and climbing to the second floor. That may be a very ordinary, trivial incident for the psychiatrist. Try to see the problem from the perspective of the patient. Right from gatherer hunter society, we are listening to the stories. Somebody said, I think the relationship between the psychiatrist and the client may be equated to that of a storyteller and a listener. Evidence-based medicine deals with the populations. Clinicians deal with the individuals. The physician should not treat the disease but the patient who is suffering from it. And understanding the beacon of light of psychiatry. And here comes the empathy that is really taking us to the level of understanding. First guideline was formulated by Hippocrates in his Hippocratic corpus. I'm not going to the previous historical issues and anecdotes with reference to guidelines. At an individual level in the primitive phase, one doctor was treating another patient. I think absolutely the trust was existing. But when they convened as a group and they started practicing at an institution, the biomedical care was there and unfortunately there was nobody to control it. At the dawn of the 20th century, public health entered the realm of therapeutics and medical researchers started emanating. Complicated medical researchers paved way for identification of newer instruments, procedures and products, and one had to really go through a complicated protocol to utilize these procedures and products. and to evaluate, monitor, assess these new products and procedures and instruments, one has to really rely upon a particular standardization or a regulation. After the Second World War, the public health, I think, started abandoning its widened vision of environmental orientation. And it started presenting with a narrowed vision of just searching and intervention. So there is an impending need for a guideline. And the first modern guideline was formulated, propagated by the Institute of Medicine in 1992. It's nothing but systematically developed statements to assist practitioners and patient decisions about appropriate health care for specific clinical circumstances. Second, it was redefined in 2011, and it is nothing but optimizing patient care that are informed by a systematic review of evidence and assessment of benefits and harmful effects of alternative treatment options. In 2016, it's a convenient way of packaging evidence and presenting recommendations. What are the reasons for the development of the guidelines? I think the political personnel, the administrative personnel, they consider it as a kind of a response for the high rising health cost. In fact, after the implementation of the guidelines in French milieu, they were able to save 3 million euros annually, but there is no data available how many people were really addressed or alleviated from their problems. No data is available. But the doctors were practicing in a group like milieu in a hospital or an institution. There was an administrative pressure. To avoid the administrative pressure, they wanted to have a kind of a personal autonomy, and they were really looking for these guidelines. And with the guidelines, they were thinking, they were in a kind of a overvalued idea, they were able to compete in the market and regulate the quality of medical service. How to develop a guideline? Identify a particular topic, do some review of literature, find out some scientific evidence, formulate an expert group. Never be satisfied by just adding 2 or 3 people who publish some research papers in the national as well as the international arena. It should consist of an advocacy group. It should include representatives of the patient population. And more than that, it should include psychiatrists from the secondary and primary and tertiary level, because they know the ground reality. But unfortunately, I think in our Indian subcontinent, I think most of the guidelines are compiled, implemented by the psychiatrists working in central government institutions and never had any kind of experience about the rural milieu where I think multi-ethnic, cultural, magical, religious factors, they play a very significant role. Find out an evidence and translate all this evidence into a kind of a recommendation. For each and every recommendation, explain logically. Come with a strong evidence. Then it should be very confident, and you should really highlight the strength of the evidence. And also you should really enumerate the differing options. More than that, there should be a clear language. Avoid clinically appropriate or if necessary. I vividly remember DSM concept of schizoaffective disorder. It's neither schizophrenia nor affective disorder, but unfortunately it is a kind of a waste paper diagnosis. And there is another diagnosis, psychosis, not otherwise specified. I think that is also probably most of the postgraduates in the early stage of their training, they invariably make this diagnosis. They don't want to commit whether it is schizophrenia or affective disorder. That is another issue. These are all the process. Define the patient's factors. Define the disease factors. Whether the individual is in the disease is the acute phase or in the chronic phase or in the recovered phase. And what about the drug factors? Which route you are going to administer? How frequently you are going to administer? And whether you are going to have another co-intervention and outcome, probably based on clinically important endpoints. Is there any kind of a comorbidity which is usually ignored, neglected, and sidelined? This is an evidence pyramid. We have lab tests, animal studies, ideas, editorials, opinions. For example, American Psychiatric Association compiled a guidelines for depression, but unfortunately most of the opinions are information garnered for the expert group. I think that were from information published in brochures and researches conducted by one particular pharma company, nothing else. And there are case series, case control studies, cohort studies, RCTs, and meta-analysis. Coming to cohort studies, this can be linked to the natural experiment. Large populations may be followed over an extended period of time. It is an alternative. RCT is the gold standard. It is an alternative to RCT when it is really becoming unsuitable or unethical. Again, you have another risk of selection bias. Case control study, it is ideal to investigate the risk factor. When the period between exposure and outcome is very, very extended, this is going to help, but unfortunately you have observational and recall bias. Case reports, they can really throw light about the benefit as well as the harmful effects, but unfortunately it is not controlled and there is a flawed design. Cross-sectional studies, cheap, quick, easy, can be conducted with a simple questionnaire, but unfortunately if there is no response, and if the selection bias is there, I think it's going to really give varied results. RCTs are good, gold standard, because there is blinding of researchers, clinicians, everybody. But unfortunately, if the participant really in that research, if he comes to know that he is participating in the treatment, and if he subconsciously, if he alters the behavior, that may lead to systemic errors and that may produce varied results. Systematic review is ideal, but unfortunately that is not statistically analyzed. In spite of all this information, in 2009 and 2010, top 5 ranking journals, Neuron, Journal of Neuroscience, Nature Neuroscience, 50% of the 157 articles that were focusing on behavior-related issues, they did not have proper methodology. If such is the case in American milieu, think about other papers in other places, including Southeast Asia. What are the objectives of clinical guidelines? There are tall promises. It enhances appropriateness. And second, it is improving quality, maybe for a government, maybe for the person who is really formulating the health policy. At a generalized level, right, it is improving the quality, but at the individual level, still the question is there. It is leading to the better outcome and improve cost effectiveness and help authorities to decide approval of the drugs. Imagine a particular guideline, 2 or 3 drugs are recommended. Other drugs, I think probably they may not be approved by the government. And last one, I think, if the guideline is probably compiled without addressing the comorbid issue, that area may be founded and future research may be conducted in that particular area. And the updated, revised guideline that may incorporate comorbidities. What are the advantages? It promotes interventions. It promotes distributive justice, uniform care for most of the people who are in need of a treatment. Yes, that is definitely. It is improving the clinical decisions. Sometimes, we are left in lurch, something like a Robert Frost poem. I was walking in the wood and there were 2 roads, one on the left and one on the right, and I chose the left path and that became my way and that became my destiny. Even to choose an antipsychotic. Right, sometimes we are that's a kind of a street intelligence. It helps. May decrease unnecessary hospitalization, decrease the cost of the treatment, and also certain procedures. Ideal for prospective and retrospective audit, so it is ideal for research, and there is a medical legal protection. Unfortunately, without any kind of a negligence, some side effects may emanate. I think we can get absolved by quoting these clinical guidelines. What are the disadvantages? Ignores heterogeneity. I think no two schizophrenics are similar. Imagine a father is schizophrenic, mother is schizophrenic, elder brother is schizophrenic, and younger brother is schizophrenic. You talk about genetic inheritance, you talk about same culture, same life events, same parental modeling. In spite of it, the symptomatic pattern of the younger brother is not similar to the elder brother. And there is a reason. Gene is expecting one particular event in the external milieu to express itself, how the individual is processing the experience. That is the deciding factor of the symptomatology. Imagine a schizophrenic patient who is responding to a particular antipsychotic, first generation or second generation. Something happens in the psychosocial milieu and is not responding. Or, I think previously, the schizophrenic symptoms are present in the schizophrenia, and over a period of time, affective symptoms started emanating, started surfacing. At a cross-sectional level, there is a tendency to doubt the diagnosis of affective disorder. And complexity of medical decisions that are not really addressed by the clinical guidelines. Reasonable for the patient as a whole, but inappropriate for specific situations. A person suffering from insomnia, he wants to have a deep-seated sleep without any kind of REM disturbance, and at the same time he wants to get up by 5 o'clock, probably a non-benzodiazepine, hypnotic, zolpidem, that is an ideal drug. But unfortunately, if you look at the clinical guidelines, if you really give zolpidem after a stipulated period of time, it is very difficult. He is going to have seizures. How much? I don't know. And interest of the patients may be sacrificed for complaints. Imagine he's a breadwinner and he wants to work in the daytime. Previously, when I was working in the Institute of Mental Health, with reference to tricyclics, invariably the prescription is imipramine 1BD and amitriptyline 1HS. When asked for the reason, they said, I think it is a stimulant antidepressant and amitriptyline is a sedative antidepressant. So in the morning, I think he has to work. So you have to individually tailor the dose, the drug, as per the needs, and can create medical legal difficulties by setting an arbitrary standard. I'm not able to really use one procedure or one instrument or one therapeutic intervention for the patient. For the simple reason, it is expensive. If I'm not following the clinical guidelines, something goes wrong, again, there is a possibility of getting into the medical legal issues. Expensive, especially for the geriatric population where the person is becoming a museum of diseases, and to initiate, to continue, one has to do variety of investigations, something like a mass file checkup. And the key relatives are willing to really spend for the child because they are investing for the future. Old man has become a baggage. Nobody is willing to really spend for the old man. The irony is, I think another specialist, they write cognitive enhancers. And so many cognitive enhancers for the dementia. And if you sincerely buy that prescription for 1 month, even Adani or Ambani, they will be really asking for a bank loan. Nobody is willing to spend for the world bank. Let us see the international guidelines. For acute mania, 2 guidelines favor lithium and valproate as the first line. And the NICE and Canadian guideline, I think, olanzapine, risperidone, but the recent review state that lithium and valproate, that is the first line of management. Maybe we can go for second line, olanzapine, risperidone. Coming to mixed picture, there is no problem at all. Valproate is the first line, olanzapine and quetiapine is the second line. But unfortunately, I repeat, unfortunately, if you come across an OCD patient, OCD features with bipolar manic symptoms at the cross-sectional, it is a kind of a tightrope walking. Very slowly, you have to increase the dose of anti-obsessional or antidepressant because of the fearful possibility of a pharmacological mania. Bipolar 2. If you come across a prescription where I think too many drugs, too many antidepressants, along with the anti-manic drugs, and probably the doctor is struggling. And sometimes even the clinical interview is a little difficult. You know, OCD people are assertive, extremely assertive. There may be a possibility of mistaking it as a part and parcel of manic process. Depression, lithium, yes, first line, no problem. Lamotrigine, agreed. Unfortunately, this particular quetiapine is considered something like God and GPS everywhere, especially in the guidelines of bipolar. I don't know about this conflict of interest. When you administer a particular drug, you should feel with the patient. This is not at all showing any kind of reaction or action. Rapid cycle, lithium and valproate is the first line as per 2 guidelines, and olanzapine, lamotrigine or quetiapine second line. Mania prophylaxis, lithium and valproate, universally accepted. Depression, again, there is no problem at all. And probably this type of melancholic, seasonal, anxious, dysthymic depression, no issues. When you come to schizophrenia, except Canadian guideline, all guidelines favor second generation as the first line and first generation as the second line. Unfortunately, Canadian guidelines, they recommend only the second generation. Imagine a youngster with psychotic process, say schizophrenia, and he is going to write some exam, university exam, or he is going to participate in a social event. I would prefer haloperidol. I think because you will feel the patient. There should be some action, there should be some reaction. Second generation antipsychotics, especially quetiapine, you don't know what is exactly happening to the individual. Something like a deep well without an echo, as far as the molecule is concerned, it's very difficult whether really the person is really reacting or acting. You don't know. Something like deciphering the female psyche. Coming to Indian guidelines, generalized anxiety disorder, I think last paragraph, when to stop treatments, please stop it in a slow and gradual way. Absolutely right. Patients should be encouraged to adapt alternative methods, yoga, pranayama, and relaxation, shavasana. Shavasana, I think it is a posture, voluntary posture, asana, and mindfulness. And there is a footnote. However, these studies are on small number of patients, whether single digit or double digit or no digit, and need careful review for further application. Is there any kind of a conflict of political interest? You know pretty well anxiety is probably, happening in individual and the autonomic nervous system, especially the sympathetic mode, is going for a hegemonious level, and any procedure, any non-pharmacological intervention which is reverting to parasympathetic mode would alleviate its anxiety. Why bring relaxation? Why bring yoga without any peer review studies? I don't know. Coming to clinical guidelines, bipolar disorder under special circumstances, pregnancy. Whenever feasible, probably is coming with under the cover of antibiotic, exposure to lithium, valproate, carbamazepine, lamotrigine need to be avoided. If required, lithium may be used in second and third trimester. Agreed. But it is probably based on a particular belief that oogenesis is happening in the first trimester and nothing will happen after the 90th day. Not in the second or third trimester. If you look at the RC psych site, I think the risk of extinct anomaly in the general population is mentioned as 1 in 20,000, and in the pregnant lithium mother, the risk is 1 in 1,000. So the first trimester, you are saying that you avoid. And more than that, there is a footnote. Children born out of lithium mother, They have to be followed up to 6 years for the specific developmental language disorders. You don't advise lithium for the first trimester, and you recommend for the second and third trimester. It's something like saying no to marriage and saying yes for living in relationship. And treatment-resistant depression, any depression that is not responding to fair, adequate, appropriate trial with two different molecules. They already mentioned that 50% of the geriatric population, they respond. And now they advise, change the medication, fine, augment. Augmentation is a fancy, decorated word. When a practitioner is adding one more drug, it is called polypharmacy. When the expert committee, when he is adding one more drug, he beautifully decorates, finds a word like augmentation. And there is a defensive argument. No, we are adding another drug, different mode of action. We are adding thyroid. We are adding other drugs. Even the person who is adding one more drug as polypharmacy, maybe one SSRI, maybe an SNRI, whatever drug you are adding, probably ultimately it is acting on the molecular receptor affinity level. And lithium is recommended for a geriatric population. And more than that, to be continued after 1 year, for 1 year after achieving remission. Already it is a treatment-resistant depression. You know pretty well, it could have become a museum of disease, hypertension, diabetes. And the drugs of hypertension and diabetes may really, have an impact on his renal clearance. And he simply recommend lithium for the gentleman. Another treatment, aripiprazole and venlafaxine. Guidelines of restraint for mental health services. Physical, chemical, mechanical, environmental, psychological. Physical restraint, planned and unplanned. I don't know the difference. If the person is becoming agitated or aggressive or dangerous to himself or dangerous to others, I think he is physically restrained. That is an unplanned restraint. Where is the question of planned restraint? And second, chemical restraint, it differs from therapeutic sedation. What is this? We administer drugs parenterally in order to address the compliance issue, in order to produce rapid tranquilization, in order to really make him to sleep, in order to control his aggressive, boisterous symptoms. I don't know whether he's really mentioning about the sedation that is happening in the narcoanalysis where it is not scientifically accepted, but unfortunately this is being carried out by the anesthetist and the psychologist. That's a different one. And visual observation, 1:1. Tomorrow is going to be the day of artificial intelligence. And artificial intelligence, probably that's binary division, it's going to really produce more and more complicated guidelines. Guidelines of autistic spectrum disorder without any RCT, they have prepared a guideline. But unfortunately, if you look at the prescription of autism, even the drugs are looking like spectrum, right from antidepressant to the next level, I think, recently introduced antipsychotic. Guidelines for psychosocial interventions in addictive disorders without any follow-up and without any aftercare for persons. If at all one area where the art of practicing psychiatry, that is really gaining its importance, it is a place where you have to practice sex therapy. Your guidelines is not going to help. You practice, you recommend Viagra, to have an experience like Niagara or hyperdapoxetin probably acting on 5-HT1/8C receptors. It's not going to help unless until you really understand the language of the patient. Already the person had become the victim of misconception and he is in a perceived impotent level. You have to be very familiar with the slang. Maybe English-speaking patient, I think you can really ask. You can really get all the information. And if you are not aware of the word temper, finished. You cannot really already the individual may not be rising up to the occasion whenever is required to. So also in the interview, we will not also rise up to the occasion to alleviate the problem of the patient. I always say, whenever a female postgraduate, if she is really, able to take a good sexual history from a male without becoming embarrassed, without making that person embarrassed, or a male getting a sexual history from a female, that's wonderful. He can garland his ego. He can really be overvalued that he had sharpened his skill of interviewing process. I want to really share one experience. I asked my postgraduate really, ask about masturbation. கைப்பழக்கம் இருக்கா இல்லையான்னு கேட்டிருக்கலாம், முடிஞ்சிருக்கும். இவன் உட்காந்துட்டு அவரை உத்து பார்த்தான். அப்பயே எனக்கு தெரியும் சனி சம்மணம் போட்டிருக்குன்னு. ஐயா அப்படின்னா, சரி, உங்களுக்கு தொப்புளுக்கு கீழே இருக்கும்பொழுது இருக்கும் உறுப்பை கையை வச்சு நீங்கள் அதை மேலும் கீழும் வாசித்து அப்படி இப்படி இதுவாகி உச்ச சந்தோஷத்தில் ஆஹான்னு என்று ஒரு ஃபீல் ஏற்பட்டு திரவம் வெளிப்பட்டு வந்திருக்கான். என்னடா சாலமன் பாப்பைய பட்டிமன்றத்தில் கூட இவ்வளோ விவிடாக பேச மாட்டான் இல்லைடான்னு அவன் பயந்துட்டான். சிம்பிள், unless until it is a kind of a magician observer milieu. Make him to feel with you, on par with you. Guidelines for the child sexual abuse. Beautiful. There are so many instructions for the magistrate. He should not encourage the child to narrate the information. He should not hurry the child to disclose information. And he should not ask the child to enact what had happened. 3 days back in Hindu, there was a POCSO case. The accused cum perpetrator was arguing there was a plan. People are really exploited the situation and probably, with the child, they are trying to send out of the school. To quote the magistrate's word, to shoot from the shoulder of the child. That was the sentence by the magistrate. Sometimes he has to clarify. And our guidelines with reference to child sexual abuse is not at all clear. It is nothing but a seminar or a symposium compiled by the postgraduate. Imagine a 17 plus male having consensual sexual relationship with a 17 plus female, and the mother of the 17 plus female files a complaint to the court. Finished. It is not only coming under POCSO, it is not only coming under rape for the minor. Setta Sidakari. And no laws is really favoring universal. It is extremely favoring the female sex. I'm not a MCP, please. I was thinking that IPC 377, I think it is really universally acceptable even before decriminalization of that particular section in December 2009 in Delhi High Court. Unnatural offences. Having a gay relationship was punishable, but not the lesbian relationship. This is the situation before the decriminalization. And nobody has really formulated any proper guidelines how to construe legal insanity. It is a retrospective falsification. And you have to really, tell about the past mental state just 2 years back with the fabricated jigsaw puzzles. No guidelines for forensic. I went through everything. They mentioned testamentary capacity, what is probably competence. Again, they are rewriting textbooks, not the guidelines. And there is a problem in American guidelines. 100% they had financial ties. And I'll switch over there. I'll skip this slide. Coming to the third part. Psychiatry is different. Anybody come to medical OP and say, Doc, I have chest pain, I have palpitation, I have difficulty on breathing. Yes, this can be relied upon. The therapist or the doctor can really go for an examination, find out a low rumbling mid-diastolic murmur, heard well at the bell of the stethoscope, and the patient is in left lateral position, and can constitute the diagnosis of mitral stenosis. Unfortunately, in a psychiatric OP, if somebody comes and says, whenever I come out of the house, the neighbor girl is giving different looks. I think she is liking doctor. I don't know whether she is loving me. Tell me, doctor. It may be true. Or the looks are meant for his younger brother. Or it may be a looking Chicago and seeing New York. Concomitant strabismus that was misinterpreted by our unfortunate client. then if somebody is coming with a relative, not with the wife, or if he's saying, my wife is having illicit relationship with the spouse, and the relative is already a Googled doctor, and he may not be really giving any kind of information. If the suspicious nature is true, he is going to get antidepressant. If not, he is going to get antipsychotic. You have to clarify. Quite often patients would come and say, I doubt. Immediately if you start doubting the diagnosis of paranoia, you are gone. On further inquiry, he may say, I doubt whether I will be really doing any work in a perfect way or not. That may be a latent, implicit OCD. There should be a guideline for guidelines. It should be subjected to agree instrument where there are 7 domains and 23 questions, and that should really highlight the relevance. I'm not going to talk about, just give me 3 more minutes. The previous paradigms. Currently we are in the biopsychosocial model. The biological model is making advancement rather than the psychosocial component. The advancement of the biological model component that paved way for identification of etiopathogenesis, and that resulted in classification. But unfortunately, while compiling DSM, Spitzer was really unhappy. He was hostile towards Freudian psychoanalysis. He erased the word hysteria. He split hysteria into 5 different categories. And there is no word called neurosis. The 100-year-old famous word neurosis is not having any place in DSM. It's split into 5 different categories. Is it really possible to really understand, treat a dissociative disorder with just neurobiological issues? No way at all. And research made a lot of advancement. Psychopharmacology, we are able to really, identify the intricate issues of the neurophysiological mechanism, structural similarities in the brain, and also occupancy of the neurotransmitter, whether in excessive level or deficit level. In spite of all this, there is no specific biomarker. In spite of understanding the chemical imbalance theory, there is no diagnostic test for a neurotransmitter. Is it possible to really treat schizophrenia with the psychosocial treatments alone? Initially, we were with the brainless mind and mindless brain. Now we are going for mindful brain. Slowly from the biopsychosocial model, I think the hospital, general hospital psychiatry, there is a biomedical care was there that was really acceptable by the other specialists, other departments, and less stigmatizing, but unfortunately less humanistic issues are there. If DSM was compiled based on Aristotelian principle, ICD was compiled on Platonic principle, what is needed? A guideline, a proper classification based on Hippocratic principles where humanistic issues are there. Last slide. There has to be a communication. And what should be in a position to deal with emotions? Patient may be aggressive, agitated. You cannot respond. Second, humility. I'm not saying that you have to be subservient. No, not at all. You have to be humble. Try to really convert the interview session in a very ordinary level. The person should not go for any kind of undue anxiety. Emotional quotient. There was a beautiful article in Indian Journal of Psychological Medicine. How psychiatrists were chosen by the relatives of psychotic people. The top priority was given to emotional quotient of the psychiatrists. Emotional quotient is nothing but understanding one's emotions, understanding others' emotions, understanding the interactions between one emotion and another emotion, and out of this, trying to achieve the beneficial effect. Deductive reasoning. Whatever available information, you try to really arrive at a diagnosis. Not only that, if other specialties are arriving at a diagnosis, we are thinking about differential diagnosis. Symptoms are mutually exclusive. There is no pathognomonic feature in psychiatry. There is no sine qua non in psychiatry. And more often, inductive reasoning is there. It is something like, with the missed parts of the jigsaw puzzle, you are trying to solve the problem, empathy. So, I would like to conclude by saying that clinical guidelines are something like Google Map. Fantastic. You know all the roads. But imagine to commute in Madras, in Chennai, where metro works are happening, and probably so many one-way roads are there. You have to reroute, right? And something like, guidelines, they show the direction, but they are not taking us to the particular destination. In administration, practice guidelines, they have the flexibility of the army cart and rigidity of a pro-Christian bed. Finally, you may ask what to do. You are buying a branded ready-made shirt. Yes, wear it. If it suits you, fantastic. If clinical guidelines are really applicable for certain patients, agreed. If the branded shirt is not really suitable, go for alteration at an individual level. So, art of psychiatry. Psychiatry, somewhere that is more significant. And somewhere I think 60% art of practicing psychiatry and 40% of understanding psychiatry. Everything what you heard now was an opinion, not a fact, a perspective, not the truth. Thank you very much.
Thank you, sir. It's a wonderful presentation on this topic. Sir, you initially emphasized the strength of guidelines, then go on to explain the limitations of guidelines. And I think this is very important to understand, especially the budding psychiatrists who are more interested in following ICD-11 and DSM-5 text revision. People are more inclined toward symptom counting and treating the symptoms. You well explained how we need to be more empathetic and we should focus on listening, understanding the patient's illness experiences. You had done great work, sir. Now, anything you want to?
Any questions or any clarifications from the floor?
Thank you, sir. Thank you for a wonderful discussion. As you said, guidelines are like Google Map, and experienced psychiatrists are like the auto rickshaw drivers of Chennai who can guide safely to the designation. Sir, what about protocols and guidelines? And what about the role of artificial intelligence? Nowadays, we are in the era of checklist. Even a very good computer can diagnose if you feed the symptoms. And it can even treat if you give all the data. Just like we are talking.
Very interesting question about artificial intelligence. Psychiatry is already becoming legalized, and artificial intelligence is already disturbing us, especially in the form of marking our attendance in the medical colleges, private medical colleges, biometry. It is certainly scoring over the natural stupidity. There was a period, man was harboring a delusion that he cannot really the artificial intelligence of the computer cannot match the intelligence of a human being till 2016. If intelligence is the factor, playing a chess game, the grandmaster, I think he is considered to be the most intelligent person under the sun. 2016, there is a software called Stockfish 8 that learned all the moves of all the grandmasters in the world, and that was able to predict 7 million moves. It can foretell 7 million moves per second. And that was able to establish a victory over a grandmaster. That learned from human beings. And subsequently, Google was silent. In 2017, December 7, 2017, Google compiled another software called AlphaZero. AlphaZero had a faith on its self-learning. It never really collected any data from the grandmaster's final games. It really learned on its own But that was able to predict only 80,000 moves that can predict or foretell 80,000 moves per second. But that was playing with stockfish. 800 games it played against stockfish. It won 22 games and tied with 78 games. This was an illustration to say that even intelligence can be manufactured with the artificial intelligence. But in spite of it, the machine learning, it is going to be like a binary way. Binary way, it is not going to help us. See, for example, the best person, I think even the individual is probably keeps on changing his attitude, and probably his attitude is changing, the altitude is also changing. Attitude changes your altitude. At times we change little bit, increase the dose, decrease little bit, and we individually, it's like tailoring. I mean, it's the most difficult job. There are two jobs under the sun. One, writing a good, complete love letter. Ramanujan must be knowing. Or you would have received so many love letters, that's a different issue. Second one, stitching a blouse for the female. It has to be appropriate, it has to be adequate. And whenever a heroine is booked for a particular movie, I think immediately she goes for a ENT, dental surgeon, a fitness master, nutrition specialist, and the tailor. The blouse will become a property of the set. For another 3 months, I think probably she cannot really put on weight here, there, because that should be, they are not going for any kind of a ready-made shirt. Ideal clinical guidelines at an individual level, it is a pipe dream. It is an utopian one. Generally, as a health secretary, as a policy maker, I may be contented, I may be really gratified that the health status, psychiatric improvement is there to the extent of 17%. But unfortunately, கவுந்தம்பாளையத்தில் ஒருத்தனுக்கு வந்து ப்ராப்ளம் கைட்லைன்ஸ் மூலமாக ஒரு வேலையும் நடக்கலை. It is an individual issue. The doctor knows everything. Each and every case is probably, I mean, it's a guideline. It is a story. I think we learned so many things from the patients. The pharma, probably they are recommending some drugs. Unless until you really know the effect from the patient, you will not be really confident to prescribe the particular drug. Protocol, everything is legalized. Yes, probably to get absolved from the medical legal difficulties, yes, you can follow guidelines. But strictly speaking, are we really taking the proper dose of drug for a proper duration if we come across any personal ailment? No way at all. It is an individual level. And the individual dosage, the treatment aspect, that is dependent upon so many issues. That is dependent upon the financial status of the individual, the commuting distance from his residence to the probably the clinic, and the availability, affordability. Very difficult. Protocol, something like a dream scene. The heroine may be really circling around the tree to find out the sense of gravity or specific gravity. In reality, if I start really circling around a tree with my spouse, finished. I have to look for a guideline from Ramanujan whether I'm a psychotic or borderline. So guidelines, they don't work. It may give a direction. See, unfortunately, we have to think in terms of a differential diagnosis rather than diagnosis. Our field is we are not really happy when somebody, the postgraduate, makes a diagnosis of particular diagnosis because symptoms are mutually exclusive. There is no specificity. And each and every patient is different. Very difficult. That's where the art of practice in psychiatry, I think if you really satisfy one patient, sir, I'm really happy. Imagine a situation where obsessive, they come for the 5th review. They know pretty well you are going to write the same fluoxamine, same clomipramine, same level. In spite of it, probably he comes. He feels that there is a comfort zone. There is a beautiful book, Men from Mars and Women from Venus. And the obsessive, something like a woman who wants to resonate. He will question us and he will question our answers. He wants to be understood and he is not seeking any kind of a solution. The connectivity, the comfort zone, probably a kind of a condition that is making him for regularly coming for the review. That's it. That's where the art of... my professor used to say, I used to ask my professor, how to really... some of our colleagues are specialists, other departments, they expect us to talk like incessant way like a radio jockey. அது வேற சொல்லுவான் வந்து 2 நாளா என்கிட்ட பேசுவான் எல்லாத்தையும் டாக்டர்கிட்ட சொல்லு. And he expects us to be a hypnotized goat. It's not possible. Within 5 minutes you are able to establish a connectedness in the therapeutic milieu. Even after 30 minutes, very difficult. கஷ்டமா இருக்கும். We are not able to really go beyond a meaningful conversation in spite of having normal issues. So protocol, I think, may be ideal for, I think it is a defense lawyer in case of medical legal difficulties. That's it.
Why I asked us, there is a game called Akinator, sir. So from Alexa, we have to imagine someone and it will find out. So I imagined KB Sundarambal. It asked some questions and it found out.
Remember, if you imagine one person find, I am imagining 4 people. Alexa will be inconclusive. I think it's a little difficult. There's something about imagination, it is something about fantasy, and nobody has trespassed to the fantasy. KB Sundarambal.
It found out in some 10th questions, somewhere like that. And Sujata, he wrote in En Iniya Indra, பொய் சொல்ல தெரிய ஆரம்பிச்சுன்னா that is the ultimate aim of ஒரு கம்ப்யூட்டரால பொய் சொல்ல தெரிஞ்சிருச்சுன்னா it will
it is very difficult.
Human being, and now they have come out with artificial intelligence which can lie.
I confess, we think that we are able to really know, we are able to really make our spouses believe all our statements, but unfortunately we miserably fail. I think they know we are lying.
I think this may be the last question.
Sir? The guidelines says yes. Individual case is all right. I think in Karnataka there is one case. A person made tall promises for cognitive behavior therapy, and wife of a IAS official, she came for cognitive behavior therapy after paying through the nose. After 5th therapy, she filed a case. I am not showing any kind of improvement, and this was a tall promise. I don't know what had happened, because people know they go for legal issues. Imagine 1 in 100 case. I think if it is really presenting with unwanted, untoward side effect, you had it. Guidelines, probably it's for medical legal issues. It protects.
Thank you very much, sir, for the wonderful presentation. To sum up, practicing psychiatry is a scientific art. It is not an artistic science. It's a scientific art. There is a guideline. Yes, you follow the guideline, but you can deviate here and there. And guidelines are only to guide you, not to follow. Yes, in individual levels, artistic things takes up the highest value in dealing the patients one-to-one. I think he has done the justice to the topic of science subverting the art. I think it is not subverting. Science is definitely complementing the art of psychiatry. And I conclude this. Thank you very much.
Thank you, sir, for the enlightening session. Now it's time to honor our chairpersons. May I request Dr. Sivasailam, sir, to honor Dr. Bhaskar, sir. Thank you, sir. May I request Dr. Ananda Krishna Kumar, sir, to honor Dr. P.P. Kannan, sir. Thank you, sir. May I request the chairpersons to now honor the speaker, Dr. T.V. Asokan, sir.
I'll say that.
Thank you, sir.
Sorry to interrupt, we're already late by 45 minutes. So I have another announcement. We initially said that the free papers are there for both Saturday and Sunday. So initially it was 1 hour on Saturday and 3 hours on Sunday, but now there's a slight change. Free paper session can be presented on Saturday for 2 hours. That's between 3 and 5 p.m. And on Sunday it's as usual. Thank you. Now we just move on to the next session.
The next session is on undergraduate psychiatry, What We Need by Dr. K. Raman sir. The chairpersons for the session are Dr. Rajeshwari ma'am and Dr. Ragutaman sir. I call the chairpersons onto the stage. A few words regarding the chairpersons. Dr. Rajeshwari ma'am is a graduated from Tanjore Medical College, 1979 batch. She finished her MD Psychiatry from IMH Chennai in 1994. She was Joint Organizing Secretary TANPSYCON in 2003 and served as an Executive Committee member Tamil Nadu IPS between 2004 and 5. Also Organizing Secretary of TANPSYCON 2017. She had recently retired from government service after 31 years of service as Professor and HOD of Government Mohan Kumaramangalam Medical College, Salem. A few words about Dr. Ragutaman sir. Sir is a professor and HOD at PSG IMS Institute of Medical Science and Research Center. He completed his MBBS in 1992 from Coimbatore Medical College, finished his DPM in 1995 and MD in 1999 from Christian Medical College, Vellore, completed his DNB in 2001. And he also holds a certificate of completion of specialist training awarded by the Specialist Training Authority of the Medical Royal College, UK in 2004. Has 4 international and 8 national publications, has authored chapters in Handbook of Psychiatry, South Asian Perspective, and also contributed about cannabis assessment and diagnosis of dependence, published by the Drug Dependence Treatment Center, AIMS, New Delhi. I now request our chairpersons to introduce the speaker to the gathering.
Please come. Good evening, everyone. I am having a pleasure to introduce Dr. Raman, who is going to talk on a very, very important topic. In which venue we can have such kind of discussions, where we have postgraduates, academic teachers. Only in conference like this, we can talk about undergraduate education and the importance of psychiatry. Dr. Raman is now working as a professor at Savida Medical College. He did MBBS at Madurai Medical College, MD at Kasturba Medical College. He's got a postdoctoral fellowship in child and adult psychiatry from CMC Vellore. He got Young Psychiatrist Award from Second World Congress of Asian Psychiatry. He is a recipient of Nilafar Award for Best Paper on Early Intervention. He is a recipient of a lot. Recipient of 5 top research grant by Minds United Trust 2001. He edited and authored a book on development of infant and child, normal and abnormal. His areas of interest are school mental health, workplace mental health, positive psychology, parenting, postgraduate training and research. As I was hinted, we are running late. So instead of me talking about this topic, can I ask Dr. Rajeshwari to introduce this topic, and our distinguished speaker can start.
At outset, I thank the organizers for giving me the opportunity to chair this session. In my observation as a teacher, for the last few years, I have been seeing the undergraduate students shows more concept. Concept means they are very intelligent. They seem to know the concept of psychiatry than the yesteryear students. and they seem to know that they have the good attitude towards the psychiatry as a subject. And I have seen even the medical curriculum which has been developed in the recent years, and it is from the current year it is being come, in which the psychiatry has given the most important, more important, rather than the scientific sessions, it is also giving the training on the art, as Dr. Ashokan was talking about. And the curriculum includes doctor-patient relationship, empathetic approach, and other things. It is being included in the recent Medical Council of India curriculum. So, the future of psychiatry seems to be bright among the undergraduate, but it is still a beginning. Let us listen from our speaker what is in store, what can be done for the undergraduate to improve the undergraduate psychiatry. Up to the speaker.
Respected chairpersons on the dais, thank you for introducing me, sir. And at the outset, I would like to thank the organizing committee of IPS Tamil Nadu chapter for giving me this opportunity. And I also would like to extend my gratitude to my professor, Dr. Shanti Nimbi ma'am, for the academic input to this topic. So moving on to the topic per se, as we are running short of time. So the topic is undergraduate psychiatry. I'm sure that there are a lot of senior experienced teachers who would be also giving input at the end of the session. So what I will be doing is, so I just thought I will just give you an overview about the new competency-based medical education curriculum, which is introduced in 2019. I'll give an overview of that and what are the merits and demerits of the CBME curriculum. Some strategies to improve UG psychiatric training, and what are the challenges and how do we go about this undergraduate psychiatric training more effectively. This is just to give you an overview of timeline on how psychiatric teaching for undergraduates started, starting from the board committee in 1946, which started with the recommendation of establishing or having a psychiatric setup in a teaching hospital or a general medical setup. It just moved on to actually conducting few seminars and workshops on some of the national institutes in our country. And it also, like when NMHP was proposed in 1982, so it mainly focused on the deficiency of training and for the mental health services, and particularly focused on how primary health practitioners should be actually trained for on mental health. And then there were a series of committees, particularly the Bajaj committee in 1986 talked about innovations to the teaching methodology, particularly for in undergraduate training. And a strong recommendation to MCI, because like we know that our teachers in the field have been fighting for actually inclusion of having a separate exam for psychiatry in the undergraduate curriculum, which is still not happening. So let's see whether the CBME curriculum has anything to add new to this or not. So MCA brought out certain guidelines, but there was a huge gap in incorporating what is required for undergraduate training. And there was UG Psychiatric Task Force recommendations made many times to the MCA as well. And finally, in 2011, MCA made a list of recommendations. If you just look at the recommendation, only thing that actually materialized was 2 weeks of psychiatry posting internship. So we all know that, like actually when I was doing MBBS, I did not have a psychiatric internship. So now you all know that like most of the students will be coming for 2 weeks of psychiatric posting, which is mandatory. So it's not optional no more. So 2 weeks of psychiatry internship is mandatory. So that was the only recommendation which was actually implemented. And but the NCI in 2011 itself recommended to increase the teaching hours from the existing 20 hours to 40 hours of teaching. And the clinical posting duration then existing was 2 weeks, which is too less for psychiatric training. And they also said that like now what is the current scenario is the general medicine department will be actually framing questions, or we will be asked some question bank in psychiatry, and general medicine department will choose these questions for psychiatry, and we do not know who actually corrects the exam paper. So it's just like 5 marks in the final year exam, theory exam. That is the current status that is existing. But MCA recommended that we need to step up this and we need to include psychiatrists for setting up the question as well as correcting the answer paper, which again is a big area of debate. Internal assessment should be made compulsory, which was also a proposal, but again, it varies from the institution, so we still have not achieved it. And they specified that integrated training, psychiatric training, is what is going to be for the future, because we are looking at a dearth of psychiatrists still. So definitely, if we have to actually include or expand the mental health training, so we really need to actually approach it from the primary healthcare level. So which means that the primary physicians or the primary care physicians have to be given adequate knowledge during their undergraduate training about the psychiatric aspects. So now, where are we in our country? So is the psychiatric training for undergraduate adequate or not? So like on comparison with other countries, we find that like we are still lagging. Even among the Southeast Asian countries, Sri Lanka, Nepal, and Malaysia, so they all have a mandatory clinical exam for psychiatry as well as theory to be eligible for achieving the MBBS degree completion. So it is mandatory. So even like that is part of their curriculum. So it's not that like you train for 2 weeks and you take lectures for 20 hours and then that's it. So it's not like that. So some of the countries are very rigid at that, like there should be a psychiatry exam and which is mandatory to be passed to achieve the final MBBS degree. So coming to the Western countries, we all know they are just far ahead in terms of their psychiatric training. So just for comparison, I've just posted this. So now just coming to the major topic for today's this undergraduate training, it's competency-based medical education. I'm sure that like most of the teachers in the medical college institutions will be aware of the CBME curriculum, which is going on from the time of 2019. So unfortunately, COVID came in, so we do not know, many of us are really clueless about how to execute this, how to implement this curriculum with the number of students in many institutions being 250. So like that is big challenge for us, like with COVID in place, how do we achieve this clinical training to take place? What is this competency-based medical education aims at? What is it looking at actually? Previously it was always knowledge. Now it is very clear that like we need to actually not only impart knowledge, but we need to impart skills, values and attitudes. There is a module in the first year called as ATCOM module. So attitude ethics module is there. So where also they are just asking psychiatrists to contribute some value-based courses, value-added courses. So which is one of the important courses that we have prepared is communication skills. So for the first year itself, we can actually involve the psychiatrists for teaching communication skills. So it's like a module which is prepared, which will be teaching the skill as well as assessing their approach, competency in that skill. So what does it aim at in terms of final focus of learning? It actually encompasses all the areas of like Miller's pyramid, like starting just now from know-how, not just know, but know-how, show and show how. So finally, the candidate should be able to perform certain skills and competencies independently, and it has listed out a list of competencies which has to be performed under supervision and then which have to be performed independently. So it doesn't focus on just gaining knowledge, it emphasizes on patient care, practice-based learning, system-based practice, professionalism, that is what like it talks about like human values and interpersonal and communication skills. So this is a huge difference from what MCA was insisting upon, although most of the things what MCA was talking was only in paper, but it was not translating into practice. So now only sir was talking about like how psychiatry has to be taught. It's not just guidelines. It is like patient, like bedside teaching. Or like a senior most psychiatrist, like based on his experience, he is able to just say that this is going to be the diagnosis. But like I read from the textbook like ICD or DSM and I compare and I get confused. So finally it just focuses or encompasses patient-oriented care and student-centric learning. So now coming to the merits of CBME curriculum. Now they have expanded very clearly, they have told about what are all the competencies that has to be covered by each department. So for psychiatry, there are 19 topics, so covering substance abuse, somatoform disorder, dissociative disorders, and personality disorders, psychosexual disorders, gender identity disorder, everything on has been covered under the 19 topics. They have divided each topics into 117 total number of competencies. Now, from 20 hours of theoretical teaching, it has been increased to 40 hours of theoretical teaching, which is a welcome move, definitely. From 2 weeks of clinical teaching posting, they are going to have 4 weeks. Previously, they used to come to us only in second MBBS for 2 weeks. Now they are going to come to us in third MBBS also for 2 weeks, where they will be having integration of the theory topics as well. It is more objective, and there are some clear guidelines. Of course, we still have a lot of queries on certain areas. Inclusion of formative assessments. So previously we were just having only summative assessments. Formative assessment is nothing but like you will be observing the student as and when they perform. So even our PGs, we don't sit with them and actually observe as they take the case. But now formative assessments for PG, CBME curriculum for PGs are also in existence, but that's again, it's going to be implemented very soon. But for UGs also, they talk about formative assessment. So it will be like on a daily basis, you will be assessing the UGs based on their competency and their clinical skill, their attitude towards the patient, how they are actually able to connect to the patient professionally. So all these are assessed to formative manner. Less number of didactics. So they're just going to throw away with this didactic lectures. It has to be as minimal as possible. So you're not going to have like one PPT presentation. It's not going to work out in current undergraduate training. So it has to be more of small group discussions, interactive sessions, as creative academic sessions as possible is what they are looking at. And as I highlighted, it has to be student-centric method of teaching. So now CBME also talks about very clear guidelines on integration with other disciplines. These are all the disciplines where psychiatry is integrated with. Starting from physiology, where they are supposed to teach on physiology of learning and memory, where they are supposed to learn about, we have to go and take. So the physiology department will be also there, and we will be covering those topics, and physiology department will be contributing their part. The psychiatric aspects will be covered by us. So that is what this integration is all about. It talks about horizontal integration and vertical integration. Horizontal is the same year, what all subjects are. I can just go and integrate with physiology means it will be vertical integration. So pharmacology, we have 6 competencies. In second MBBS, it will be horizontal integration because second MBBS has pharmacology and we also come into picture. So we have to integrate with pharmacology, community medicine, forensic medicine, general medicine and pediatrics. They have defined certain competencies. There are few competencies which are really good because general medicine, it talks about how to identify and refer to a psychiatric department from the general medical pool. So this is very important from a clinical point of view. So, but still, there are a lot of arguments on how we are going to implement this integration. So coming to the demerits, of course, we know very well that there are many medical colleges where Department of Psychiatry is functioning, but the number of faculties might be very less. In such cases, in such situations, it might be very difficult to actually implement this CBME curriculum because now we are going to have students almost on all our working days. Previously, they used to come only in batches and there will be a huge gap, and we all know that if it is going to be the pathology, microbiology or pharmacology exam, they're not going to turn up at all. So I was actually doing the same because I never entered. I just had attended Dr. Sierra sir class, theoretical class, and our exam, just before our exam, we had psychiatry posting and I couldn't attend. So similarly, only our students also do, and whenever there is an internal exam in pathology, they don't turn up for the class. So this is what was happening. So with all these lacunae and deficiencies, it affects the motivation of the faculty at an individual level also. If one student turn up, the faculty says you read for the internals and they don't take up the class. But see, nowadays it's going to be, even if one student comes, we need to take the class. Because we'll have to account for the attendance for that student and we'll have to cover that CBME competency for that student. So that is what CBME curriculum is very particular about: attendance to appear for the exam, internal assessment marks to appear for the exam. So these are all very well defined, but how it is going to be practically implemented is what we are going to discuss. So there is always a doubt about how internal assessment although there is a CBME guideline says that like we have to contribute, our internal assessment in psychiatry will contribute to the general medicine. But how much percentage our general medicine department should agree with it, and all these are becoming a big area of debate. CBME mentions about competency. So that means a student is able to actually learn the skill. So it also talks about whether that he has learned the skill at first attempt or can he be given any remedial attempts. But the number of remedial attempts is not mentioned in the CBME curriculum. So that's again, so our pattern was always, okay, you just read something and we'll give you an attendance. If your internal assessment mark is low, you just like make up for that by actually writing some notes on that, and then you will be marking the internal assessment marks. This is what was happening before. Now it is very clear that unless a student masters the skill or a competency, even number of times is not mentioned. So that again brings back the question of time-based learning. So we are used to actually time-based learning. Every year we'll have to finish that skill and go. But what if a student doesn't achieve that skill? Then that basically questions the competency-based curriculum at all. So essence of that CBME is being questioned. Role of institution in implementing. Again, the institution plays a vital role in implementation of the CBME curriculum effectively. So again, if that institution is not giving that much importance, it cannot happen, because like it is like NMC is going to come for visits only if CBME curriculum for UGA is being implemented. That's again being questioned. Unfortunately, are we better in terms of including more hours? But there are no certifiable skills. So the CBME also gives a list of skills which needs to be certified to get a pass or to get a completion in a particular subject. But in psychiatry, there are no certifiable skills, which is a major demerit which is being actually talked about. So now comes to the question, is training undergraduates so cumbersome? Is it so tedious? I would say that like definitely it is going to be difficult, but the outcome is going to be more rewarding, provided we are putting consistent effort. And I'm just going to give an example of our own experience, what we did in our hospital setting. So now how do we go about it? What are we supposed to do? So the most important challenge in undergraduate training is to get the students for the class. Out of 20 students who are posted for the class, 5 students turn up. 3 students turn up. Sometimes students don't turn up at all. So I have made efforts to just call them, get their individual number, call them. They don't pick up the call. They call and attend the call and say that like, so what? That will be the answer from many students. Okay, sir, I'm sleeping, sir. I'm tired, sir. Can I come and meet you tomorrow, sir? That will be the answer. So it is that kind of response we get. So now, since the attendance is made mandatory to enter be eligible for the exam, so now institutions cannot be institution have to be more strict. So our institution has become more strict in terms of like digitalizing the attendance. There is no like manual attendance henceforth. So anyways, like we are all having, like sir was saying, we all are having biometric attendance. So the students' attendance is also digitalized. That makes them accountable for their attendance and the eligibility for the exam. So now, if at all the students have to be taught or bring them for the department, it's not just like, it is a collective effort. It's not just from the faculty alone. It should be from the Department of Psychiatry. There should be an institutional policy which is very favoring psychiatric training, and there should be involvement from professional body like IPS. So I'm just going to talk about at the individual level and the department level and institution level. A teacher in a medical college setting, anybody would be definitely experiencing this kind of feeling, because if you just look at the kind of responsibilities for a teacher in a medical college setting, you will start with patient care. You are supposed to do some research activities. Sometimes like there might be a new rule by the NMC for the faculties that like only if you do a PhD, then you are eligible for becoming a professor or HOD of the department. Now it talks about completion of basic biomedical research. Okay. And PG training in PG institutions. I think most of the institutions aim at getting post-graduation degree, so post-graduation courses. NAC accreditations for colleges, NABH accreditation for hospital work, UGC like visits, NMC visits, everything actually has to be collectively handled by the teachers in the medical college institution. On top of it, past 2 years we had COVID duties for the faculties. So now where is this UG training? If you have to talk to any medical teacher talking about UG training, now they just shift the responsibility to PG residents. So UG training and allied health science training takes the least responsibility for a medical teacher. So but like I'm sure that like with more orientation about what is to be done, with a clear plan from the Department of Psychiatry, definitely this can be achieved positively. From the faculty level, what is required? All faculties in the department should be aware and be thorough or be oriented about this current CBME curriculum. Then that is what is the first step we started doing it. And the curriculum topics, and most importantly, what are all the topics we are going to integrate with other disciplines. So that like we make our integration more positive. Still, there is a lot of attitude or a negative attitude towards the psychiatrists from the non-psychiatric disciplines, which is a major drawback, a hindrance to like an interdisciplinary approach. So many times my PG calls up and says that like, sir, I get a call from the surgeon and surgery PG saying that like, you come and counsel the patient because the patient is not taking food. So that is the approach that the postgraduates like get very so offended, and they think that like they are just passing some derogatory, calling for some certain trivial issues like this. And I go up and see, sir, the patient has not passed urine for 2-3 days and his abdomen is distended. He's having so much of pain. Nobody is there to hear to him, talk to him. And finally, they just come and say that like, you just go and talk to the patient because he's aggressive. So this is the kind of scenario that we are looking at from the non-psychiatric perspective. So I'm sure that like all of us would be going through in a medical college setting when referral comes. So most important thing is like integration with other disciplines, definitely essential. And all faculties can just think of, definitely we all have some creativity and innovation, for sure. So we can always tap our creative skills in teaching methodology, teaching learning methodology to make the subject more interesting. Otherwise, what will happen, what used to happen is, there is a PPT which was prepared 5 years back by your senior. And you continue to just take that same PPT again and again and again with no addition of any new content to the, you know that like it is like advancing, but like that was happening. So because like we also did not take that teaching very seriously. So creativity and innovation is extremely important. Definitely we can tap our skills. And initiatives for different modalities. So of course, like there are a lot of, I'm really, I can proudly say that like we have in the department people who are really technologically savvy, and they can actually make the learning experience more easier and amenable for the students. So with their help, we are able to actually achieve different modalities of teaching. Reaching out to students through technology is easier always. We always create WhatsApp group for the students and try to communicate with the student. What is the class for the next clinical teaching? So that is how we try to engage the students. It's not just only academics. If there is any neutral thing that is relevant to psychology also, we tend to post. Like I have just recently posted mindfulness-based breathing, simple breathing as a type of relaxation exercise in the group. So some people felt, okay, it is something new, and they started just Googling and finding out. So some input is there in an informal way also. And most importantly, the faculties have to learn to upgrade their teaching skills. I know very well that like teaching is it's a skill which has to be learned. And as postgraduate residents also, we are the postgraduate residents. Once you just finish the PG training, you are immediately joining some institution as senior resident where you are supposed to take up the teaching job. So again, upgrading our teaching skills is extremely important. That's why we have included pedagogy assessment as part of the postgraduate training in our institution. I believe many institutions would have also started. So assessing a teaching ability of a postgraduate resident, either we have to include it as part of the 3 years training as well as assess them at the end of the training. Make teaching sessions as effective as possible. I'm sure that like there are many methodologies available. I'm not going to say that which is right or which is wrong, but you can even start a theoretical session with just like a MCQ, case scenario, or a problem-based exercise. You can talk about a movie Of course, we have very useful, actually, like our subject is definitely has reference to movies and other media. So any video clip you can actually post and then like ask the students to actually come out with some responses. Make it as interesting and effective as possible, and ultimately convey the message in a very, very brief way. Small group discussion works. That's why like they're talking about this flipped classroom and all. No more traditional classroom teaching. Teaching by demonstration. So again, like how we were taught in our undergraduation, bedside teaching, where a professor will be interviewing a patient and then we will be observing, and then these days like they talk about such kind of bedside teaching for even postgraduates. Imagine like what the plight of undergraduates. If you ask them to go and take the case in the ward, and we do not know like where they reach, they stuck with socio-demographic details. That's what we have seen. They don't know how to proceed beyond the socio-demographic details, and they'll ask 1 or 2 questions about sleep disturbance and they come back. So unless otherwise we tutor them, it is actually like a shadow teaching that we have to do for an undergraduate on an individual level or a small group level. So that is what is going to be little more successful. And linking theory and clinics whenever possible. We have created small clinical scenarios, like what even before the CBME curriculums was started, we just framed something like, say for example, a suicide attempt. Different kinds of suicide attempt and approach. So like we try to link that with forensic medicine. We try to link that with pharmacology, with alprazolam overdose. What will you be doing? So what is alprazolam? Benzodiazepine. So like we can actually think like that and make it as creative for the student, so that like he will go and read that day pharmacology also. We are benefiting because like he's reading something relevant to benzodiazepines also. Okay. So that is one another way that we have actually tried. And it also talks about like try to incorporate as much as possible about biopsychosocial model wherever relevant. So it's like that is how we are different. It's like biological psychiatry, talk about incorporation of psychosocial aspects as well. Because generally there is a talk that like of late the students' approach and attitude towards patient care is really going down. So that's why they have included this AdCom module and all those things. And nothing is like previously we learned by observation. We also had some basic ethics, but now we have to teach ethics. So that is how we are. Everything module is created. That's when like students are learning. You have to complete these hours of training. You have to complete these hours of teaching. That is how we are just landing up with, unfortunately. Our experience, so we have divided the topics, like I'm sure like everybody can just like, we will be going through these topics, like, but second MBBS we just thought like we will restrict to substance abuse, depression and anxiety and basic history taking MSc. And third MBBS we thought like we'll just go to the next level. So psychosis, bipolar disorder, organic mental illness, personality disorders. That's how we have just divided the topic for 2 weeks clinical posting. And we also divided the skills also accordingly. So say for example, rapport establishment, empathy, confidentiality will be taught to the second MBBS. And for the third MBBS, like doing an MMSc, assessing for a suicidal risk will be a skill assessment for a third MBBS. So that is how we have divided the topics. Clinical sessions, how we had planned is, now the students are coming to us 365, like almost all working days. So for the second MBBS, we have 2 hours of clinical session every alternate week, which means like there are 6 groups which are divided. Each group contains 20 students, and every day 20 students will be coming to psychiatry. From morning 8 o'clock to 12 o'clock, psychiatry undergraduate students are coming to us. Morning 8 to 12. 8 to 10, 20 students are coming. 10 to 12, 20 students are coming. On 6 days of the week. Okay, so now like we have divided plan like 40 to 45 minutes we'll have orientation on the clinical topic. The next 45 minutes will be on case discussion. But the challenge is how many patients can we show to this group is a big challenge that we need to actually work it out. So we have devised case-based minutes, and MCQs are given at the end of every clinical class. For that we seek the help of our PG residents, and competency assessment we have made it mandatory. We are going to, whether there is a need for certifiable skill or not, at the end of psychiatry posting, you will have to complete the competency assessment, whichever is basic required that we feel we can actually execute. We have already started OSCE based assessment for the previously. So which during the COVID time when we were all free, we thought like what to do. We thought like, okay, we just devised modules for OSCE-based assessments for the MBBS students. So which we are expanding. For the third MBBS, we thought instead of just doing so we will just take it to the next level. We'll talk a discussion on a case, bedside rounds, observe history taking by postgraduates, tag students, few students with postgraduate residence when they are taking a history, so that these students will observe and then they will come and discuss with us. So relevant points, the UG will be discussed with them, and postgraduate, there will be discussion higher up. Outpatient screenings. I'm sitting in the OPD, I'm so busy with the OPD, and students have come. Now we'll just be dividing across all the 3-4 consultants or 2-3 consultants, and students will be sitting beside us like how we used to have in medicine and all, or surgery and all. So like we used to have patients, outpatient screening done by the consultants, and then there will be discussion based on that. So child psychiatry is one of the topic in third year. So say for example, I don't get any child cases at all. So one day I just send them to a psychologist. They were so curious to just like learn about the IQ assessment and the psychometric tools. So there was some learning, and they came back. I just taught them how to approach a child with poor academic performance. So there was some learning. So I didn't show a case, but like I just made them engaged. At department level, active functioning by each faculty member has to be there. There should be a proactive, academic-oriented department level policies. They talk about creating curricular enrichment course. We have created few modules like how to assess suicide risk and substance abuse prevention. Like that we have created modules. Online platform and videos are for PGs we have created a YouTube channel, but for UGs we can actually talk about like any form of online videos. We can post it in the website. Introduce psychiatric concept in the first year. This is what has been done in most of the Western culture. Behavioral sciences is introduced in the first year itself, and for that like we need integration with anatomy and physiology. Take students' feedback as seriously as possible and make our presence felt in the institution. We try our level best to actually, because we want to remove the stigma. All these things are basically to remove the stigma associated with the Department of Psychiatry. So we usually conduct mentoring workshop for the faculties where we incorporate like how to identify emotional issues for the students, and then like we conduct stress management workshops for the students, so that like we know that psychiatry is existing. The Department of Psychiatry is existing. They don't just like treat patients with mental illness alone. They cover a holistic approach. Again, we can think of creating role play video banks. So like because CBME curriculum talks about how to educate a family member about a mental illness. Say for example, if a person is diagnosed with schizophrenia, how will you educate a parent of a patient with schizophrenia? For that, we can actually have a role play with the help of the interns or our postgraduate residents. That videos can be created so that 1 hour or 45 minutes we can play the video, then come for discussion. So that 1 hour, I have my own time to finish my patient care. Okay. Pedagogy training for postgraduates, as I highlighted. And there is one more thing that we thought like it will be beneficial, because active training of postgraduates who are posted from other departments, because these are the people who have also not had good undergraduate experience. So they can just like carry some knowledge wherever possible. We just make them learn psychiatry appropriately. Otherwise, what happens is like our psychiatry postgraduates goes to general medicine and neurology where they are not taken care of. Their postgraduates come to us and they are also not cared for. So we have made it very clear that like academic aspect input will be definitely there for whoever comes to the department. It might take our time. It might be stressful sometimes, but we wanted it to do because like many times like we work it out and see that like we keep blaming others. We keep telling that like the general medicine department is calling like this, the emergency people are calling. Probably their exposure and knowledge on that is very less. So we need to educate them being in a tertiary hospital setting. At institutional level, as I told you, curriculum implementation has to be ensured. Effectively implementation, enforcement of attendance is in their hands, and internal assessment is in their hands, where they have to collectively call the integrated disciplines and then make sure that the internal assessment mark is happening. Final year exam should have questions. Since we are in university, autonomous institution, definitely the policies can be changed, but at the government level, again, it requires a lot of time, but like CBME expects it, so definitely we can actually talk with the general medicine department and get, but again, it's again work for us. If at all we are going to correct the papers, set questions, then again it's work. But that is how good a candidate can be assessed when they actually complete. Creating a pro-psychiatric culture is the policy of the institution. We are really lucky to have our dean who is really pro-psychiatry. Most disciplinary behaviors, psychiatrists are involved. Of course, it's a lot of work, but still, we thought that that's how students also, now there is a follow-up of students on the student counseling cell which has increased. So now because most disciplinary behaviors, whenever what happens usually in institution is suspension. 2 weeks of suspension, that's all. And then they come back and they are on their own. There are repetition of disciplinary behaviors. So now what our dean did is, whenever there is something like this, just screen for something which is problematic behavior, whether it can be corrected by a psychologist or a psychiatrist. So see professional help. And wherever possible, we have identified so much of morbidity through that. And then so the institution plays a very important role to actually make a positive impression about the role of the psychiatrist. At professional body level, Indian Psychiatric Society is doing a lot of work, and with that work only we have come to this level. Still, although there is a lot of work ahead. Workshops are topics on like how Tamil Nadu chapter has started with UG, including inclusion of topics on UG and PG training mandatory in conferences, or that can be a separate section on UG or PG training. Reward young teachers and students at the state level conferences, identify some good teachers who are really efficient enough. Of course, the Atma Young Psychiatrist Award is there, which is considering all other aspects, Of course, teaching should also be given importance so that teachers gets motivated. Exclusive sections in journals, or creating a separate journal for UG related research work. Psychiatry exam to be made mandatory. That is going to be next exam. I'm sure most of you would be aware of it. Maximum representation in terms of next exam. If that's the push that they are doing at the national level, so that psychiatry students read. Otherwise, what happens for the MCQs also, they will just read last minute. It's SARP. We used to read SARP, skin anesthesia, radiology, psychiatry. Last minute work, because there used to be very less number of questions. So even there, psychiatry is not taken seriously by the student. So now they are pushing that there should be maximum representation for the next, so that they take psychiatry very seriously by the talent show for this was something which I thought talent show for undergraduates in state level conference. We always talk about quiz. So we can conduct debates, because quiz means only certain students who are reading will be just opting for this. But debates can be conducted, painting can be conducted, photography competition can be conducted. Everything can be just now digital. So they can just conduct. So people will get involved. More students will get involved and they know about psychiatry. Some students will come and attend some of the topics, interested students. So more interest can be created. So definitely, we used to have psychiatrists doing in the evening some shows and also. Probably we can involve UG students to do some cultural shows, so that is okay. They feel inclusive in such state level conferences also. These are all some of the IPS recommendations in 2010 itself, but needs implementation further. So what do we do next? So now we can just go back and maybe we can all question ourselves. Yes, sir. Yes. We can question ourselves, do we utilize the 20 hours of clinic and theory hours effectively? If not, what are we going to do? Do we engage interns in meaningful and interesting way? Interns are I should say that even in our department, we are finding it very difficult how to engage the interns. They are with us for 2 weeks. So now again, we are just thinking of solving MCQs along with them. They have all these online module videos, but they don't open up at all. Even though they know that psychiatry posting, they have less work. So we thought we will engage them by solving MCQs along with them. What new ways are being tried to engage the students? Do we obtain feedback from the students and modify our teaching pattern? So we can have peer feedbacks also. So we can ask one of our colleagues to sit in the class. Constructive feedbacks can be obtained. And do we link psychiatry with other areas of interest? Are we teaching only psychiatry, or can we just expand a little and say connect with other subjects and integrate during our clinical teaching itself? So what are the challenges? Again, student-patient ratio is a big challenge, because with 20 students, we cannot just interview, only we can show cooperative patients in our discipline. That's a major drawback in our discipline. So better to talk about training of simulated patients and standardized videos. We'll have to start creating a bank. Use of real patient videos, again, it's a big difficult area because ethical issues, getting consent, all those things are there. So simulated patients, ultimately we end up with that, and standardized videos. Young faculties with lack of teaching skills and abilities, they need to just nurture there and prune their skills. Institutional policies, feasibility of integration with other. Of course, these are all going to be the challenges, and we need to find a way out. Just to highlight, what did we try in this COVID time? We started a medal exam because we used to have medal exams during our undergraduation in other disciplines, and we started medal exam in psychiatry, and 50 students registered. So just going to finish. 50 students actually registered from third MBBS, which was a big surprise for us. And we had meticulous screening, theory exam, clinical exam, and 5 candidates, and we awarded them with cash prize and certificates. We have research projects by undergraduates. Every year, 10 students are posted with psychiatrists. And 10 students, they will have to guide research projects. And during the COVID time, we were able to get at least 4 undergraduate research publications. And OSCE as assessment tool at the end of second MBBS, we have started already. Again, during the COVID time, we initiated, but like it was stopped. But like we are going to restart. We are very clear about like we'll try to improve the pattern of assessments, quiz, debates, and other forms. Pamphlet competition. We just thought like we will be trying to involve them as much as possible. Involve them in World Mental Health Day celebration. Is it worth taking this painstaking task? Yes, it was rewarding for us. In 2021 and 22, we were awarded the best undergraduate psychiatry department by Indian Teachers of Psychiatry. So that was extremely rewarding for us. So we wanted to continue this. To summarize, so we need to have enthusiastic faculties. Student-centric learning methodology works better. Strengthen the medical education wing in the institution, and technology-based teaching and assessments. Student networking can be created. Students who are really interested in psychiatry, we can actually create a network, definitely. Interprofessional training and integrated teaching. So this is my department. So I would really like to thank all of them, because without teamwork, our dream would not have been possible. These are my references. Thank you. Our doyens of teachers in the past have just like struggled so much to get to this level, to get undergraduate training or teaching like more effectively. CBME curriculum has also approved. Now like it's our turn to just take it to the next level and work effectively, so that like our undergraduates are trained more effectively to actually the mental health. So with that I will conclude, and thank you so much for this opportunity.
Congratulations, Dr. Raman, for your lucid presentation on CBME curriculum and your keen interest on undergraduates to upgrade their knowledge in psychiatry. In Salem, CBME curriculum is actually a very tough curriculum, but it involves the involvement of teachers. Because in psychiatry, almost 117 topics has been there in CBME curriculum. We had a tough time to club them into 14 classes or 15 classes because they have included everything. So again, the CBME curriculum, even the first year orientation program, one particular day was assigned to psychiatry, in which we did classes, 3 or 4 classes, which group discussion, role play, and we involved the nursing students to do the role play. That is the professionalism, that altruism, compassionate, communication skills, how empathetic the doctor should be, doctor-patient relationship, emotional relationship. Everything was done. The first 15 days of MBBS curriculum, for one day, the day was related to psychiatry. So we try to implement all these qualities. What are the professional qualities the doctor should have? That is there in the CBME curriculum. One day was assigned to psychiatry, first 15 days. Then again in the second day, as he said, phase 1 and phase 2, there were so many topics were there, which is very tough to club them. And there is a specification, which topic should be there in the discussion, which topic to be group discussion, which to be demonstration, which to be the competency-based, skill-based. Each and everything is specified. And it needs horizontal integration and vertical integration with other departments. So all these has been mentioned, all these has been done. But it is a very young, but is only 2 years, as he said. 2 years it went on COVID. And the current year only it is being implemented in all medical colleges, but it involves again, it is the faculty interest, because nobody is going to question you, but what is given in the curriculum to implement, it is very difficult because it involves lot of time and planning and involvement from the student side. Only thing is, again in the CBME curriculum, there is no exam for the undergraduate, separate papers, separate questions, separate, it is not there. It is only that teaching is there. There is no assessment part, only the assessment is there, but it is not given marks. So again, it is again big lacuna. Again, there is only thing is like CRRA getting the completion certificate. Nowadays, for the first 2 years, CBME curriculum, undergraduates comes to, at the end of final year, they have to get the certificate from the Department of Psychiatry. Their attendance certificate is there. That improves the attendance of the undergraduate students for psychiatry. But as I said, he has been doing very good work in the college, implementing the CBME curriculum very seriously in the department. If it is done in all the medical colleges, I think the attitude of undergraduates to psychiatry will improve. Again, as you all know, conducting medal exams is all being done in Salem, and we do the quiz, that is a big crowd will be there. We will conduct in 2 sessions, and then we end up in selecting 2 or 3 students. So it is important that the department should involve to teach the undergraduates. It should take it as a task. Then only the undergraduate psychiatry will improve. I will give on to.
Yeah. Excellent talk. The topic is now open for discussion. Because of time limit, maybe we can allow just 1 or 2 questions.
Good evening. Thank you, Dr. Raman. Thank you, Chairperson. So we had such wonderful speakers, and the chairpersons had been ideal students and gold medalists and of par excellence. So the topic has been so wonderful and so in great detail, and every point is well taken by most of us. Maybe with so many years of hard work, I thought I also have, I'll make it as brief as possible. Stop me whenever you can. I'm Srinivasan from Chennai, and I've been fortunate to study with Dr. Chairperson, one of our brightest in the IMH, and I had the opportunity to work with Dr. Raman, and I heard of you, Dr. Raghuvathaman, and many of your students, okay, and many stalwarts here. I'm just, probably I'll restrict to the logistics area. Like, we have teachers who have to perform some job. So if you put I've been in various, putting the chart for 150 students, I'm in a medical education unit, I'm a clerk or a secretary, I'm a faculty there. So 150 students, many don't stop with that, 250, okay. Now, second year and third year, so 365 days and all that. So first batch of the person, first week or the 2 weeks, students come. They are fresh from anatomy, biochemistry, physiology, biochemistry. Imagine there had been a COVID, there had been a delay in a NEET examination, that got truncated, and they have had a lot of struggle, and some of them have been tutored by us or helped by us in counseling in various ways. Before they are entered into psychiatry, we are all involved with them. That's a different story. Now, first 2 weeks, they just from anatomy, I asked them which year were you, I have to place them where you are. Towards the end of the year, most of them have gone through many other postings, medicine, surgery, and etc., and they come to me. So, when such a tiring, such a job, so with a lot of effort, the psychiatric team is inculcating to them. Imagine, like, Bogi, which is not at reach Rameswaram, but something in Madurai. So, how would you go to Rameswaram, not in Madurai? I'm just giving a crude example because of train journey. So now, the first 2 weeks, they have not had anything about other subjects. So normally, we say general physics examination, neurology, all that has to be done, and patients should have been discussed about hypertension, some discussion, some clinical talk. I'm not saying, then go to the brain or psychiatry or whatever. So this is an area we have to work on. All of us. We are going to be slowly phased out. So all this, you would have had it in your mind. So I know, I'm sure, the want of time. Another thing is, toward the end of the year, students are slightly more knowledgeable. So I am motivated, they are motivated, we are both motivated. My colleagues are also motivated. This is another area. And now he's talking about, he put 7, 8 names there in his college. And we all know how many in different colleges, and all are motivated people to be able to present papers from undergraduates. So imagine the level of motivation there. We wish all of us are as motivated. We are such a talented people. Every one of us are. We believe so. But competency based has come only in 1991. Even before psychiatry, as he said, doyens have made effort to bring in psychiatry as a subject. Exams yet to be there. So I'm an MBBS student. I will not have an examination. 80% marks I get, irrespective of whether I touch the so-called subjects, I'm yet to pass. So how do I ensure? Especially summative examination, summative assessment are there. What will be the motivation of a student? That's a different story. These are the areas we have to plug as he has come. I don't.
They're asking.
Okay. Another thing is time slot, I said. So unless we are, the same group of psychiatrists are teaching 2 or 3 or 4 postgraduates also. And imagine the postgraduate training has to be par excellence again in a subject
Excuse me,
of
sir,
psychiatry.
sorry to interrupt. We were running short of time.
So,
Please
one or
keep
two
it
hints I
concise as
told.
possible.
The time slot, how many hours devote. And you can even pull resources from the community of psychiatrists who are not totally committed to teaching institution. Maybe they can chip in. They may be offered in the medical colleges. They can come and give their, this is stopgap arrangement.
Thank you, sir. Thank you, sir. Thank you. I think because of lack of time, we can have a personal discussion with you. Oh, wonderful. Thank you very much. Thank you.
Thank you, sir, for sharing your valuable points to improve the exposure of psychiatry in undergraduates level. I now request Dr. Ramanujam, sir, to honor our chairperson, Dr. Ragutaman, sir. Thank you, sir. I now call upon Dr. Indupati ma'am to honor our chairperson, Dr. Rajeshwari ma'am. Thank you, ma'am. I now request our chairpersons to honor the speaker, Dr. Raman, sir.
Thank you, sir. A kind announcement. For queries and clarification with poster, please contact our Joint Secretary, Dr. Preeti ma'am. And for queries with free paper presentation, contact our Joint Secretary, Dr. Bhagishri ma'am. Thank you.
Now we are moving to the next section, that is Understanding Adolescent Suicide by Dr. K. Preeti, and the session will be chaired by Professor Dr. Shadi Nambi ma'am and Professor Dr. V. Gidanjali ma'am. Now I request the chairpersons to come up on the dais. A few words on the chairpersons. Professor Dr. Shanti Nambi ma'am, she's currently working as the Professor of Psychiatry, Savitha Medical College, retired Director, Institute of Mental Health, Chennai, and Professor of Child and Adolescent Psychiatry, Institute of Child Health, ECMO, Chennai, and Professor Dr. V. Gidanjali ma'am. Ma'am is currently working as Professor of Psychiatry at Madurai Medical College and has been working in teaching side from 2005 till date and worked in 7 medical colleges so far.
Good evening to all of you, and at the outset, both Dr. Gitanjali and myself would like to express our gratitude to the organizers for this opportunity. Before we move on, I would like to introduce our speaker, Dr. Preeti. She is currently consultant at Neuro Foundation, Salem. Her MBBS from Madras Medical College, her MD from Madurai, her PDF and her DM from NIMHANS, and I think we are all proud to say that she is the first or the second batch first batch. She's the first batch of DM, Child and Adolescent Psychiatry from NIMHANS, so that goes a lot of credit to her. Her work experience belongs to the first batch of PDF and DM, as I had mentioned, at NIMHANS. She was a faculty at JIPMER from 2014 to 2020. She was a course coordinator for PDF in Child and Adolescent Psychiatry, which was initiated in 2017. And these are the list of various awards that she has received. PG Research Award at TANPSYCON 2006, Early Career Research Award in 2016 by Science and Engineering Research Board, Department of Science and Technology, Government of India. Publications, she has 46 publications to her credit till date, including research, articles, reviews, and chapters. And her areas of interest in the child and adolescent psychiatry are affective disorders in children, early intervention for neurodevelopmental disorders. She's a very eloquent speaker. I have heard her, I have chaired many of her sessions in child and adolescent psychiatry. Just a very, very quick, brief introduction to this chapter. As we know, suicide is not only a mental health problem, it is also a public health problem, and is one of the leading causes of adolescence, especially in India. And two most common reasons that makes an adolescent desire to end his life are a primary mood disorder, and as we know, the increased incidence of substance use disorders. But in the Indian culture, we have several other causes, like failure of examinations, stress and coping to take up entrance examinations, peer influence, parental expectations, and the COVID isolation has made the situation worse. And the recent NCRB, that is National Crime Record Bureau of 2020, shows that there is an increase of almost 20.19% of suicide among the young adolescents, which is a very important situation that we need to be considered. And I'm sure Preeti is going to dwell into the complex area of adolescent suicide, which we all need to understand so that we can take preventive measures apart from psychoeducation and social integration, etc. Only if we understand the complex area behind this, we can help prevent or reduce the percentage of adolescents committing suicide. And Tamil Nadu, apart I think from Maharashtra, tops the list among suicide deaths in India, which also need to be taken into account. So, Geetanjali.
I thank the organizers for giving me this opportunity. It is nice to be associated with Dr. Preeti Kandasamy. Previously, we invited her for journal club in Tanjavur Medical College and Chengalpet jointly. We did during the COVID time. She was very kind enough to accept that. And later, a statewide journal club also, she was very kind enough to enlighten about qualitative study. It was very nice to be associated with her and very willing. I am very much eager and willing to hear her lecture today. And the topic also is it's an evolving world. Today now the world is evolving in many areas. Adolescents are also in the evolving period, both emotional and intelligence, and lot of changes are going around them and also in the world. And what are the problems faced by them and how we have to tackle, what are the new issues and how we can address these new issues, how the gatekeepers have to be taught, that is their parents and teachers. And I expect Preeti to give us some answers and enlighten us. On to Preeti.
Since we are running short of time, we have been requested by the organizers to be dot on the time. So I think Preeti will keep up to that. Thank you.
Thank you, ma'am. Are there any postgraduates here? Are there any postgraduates? I'm happy to see some of you because I've always been an outstanding postgraduate. I've never been inside the hall in any conference. I thank you really that you're here. This is a very vast topic. I generally don't speak for more than 20 minutes, but I think this topic, I really found it difficult to put things together because a lot of issues when we talk about not just understanding but preventing adolescent suicide. So I'll discuss about what we know in terms of the numbers and the evidence, and my conceptualization as a child psychiatrist about adolescent suicide, and what can we offer in a clinical setting. As an individual mental health professional, what is that we can really offer? Going on to the global scenario, we know that suicide is a leading cause of death among the young adolescents and the young adults. When we look at the suicidal ideation, about almost 24% of them seems to have suicidal ideation, 8.8% attempt suicide, and suicidal death contributes to about 8.5% of all the deaths. When we look at Southeast Asia, what's striking is that women in the age group of 15 to 29 have significantly more completed suicide and suicidal attempts. Ingestion of pesticides seems to be one of the leading causes or the common means access for suicide. And although suicide is something that has to be approached from a multi-sectorial approach, what I thought I would focus on, because me being a clinician, and I think I'm here only because of the term adolescent in the topic, and therefore I'll just focus on what can we really offer in a clinical setting when we sit as individual child psychiatrists or psychiatrists in handling a family or a child. The numbers in the Indian scenario, like ma'am said, is significantly high. You can see that strikingly more female than males. And I think when we see female children, I think it's important we understand the various complexities which not only involves the neurobiology but also the socio-cultural aspects. So I'll talk about the evidence. We know that the suicidal behavior is a very complex process, involves genetic, environment, neurobiological and psychological. So I'll touch upon the various aspects. Although it will appear as disconnected pieces, these pieces come together in the solving the puzzle, and I think it's important that we understand the various aspects before we can really plan prevention. Largely in neurobiology, I think the focus has shifted from the serotonin pathway to the GABA and glutamate pathway. There is interest in a lot of candidate genes. I was personally interested in the SAT1 and the BDNF. There is specific focus on the prefrontal cortex and the HPA axis. But I also see a shift in the neurobiology studies from plain candidate genes to looking at DNA methylation and the effect of epigenetics, about how epigenetics play a role in bringing about a change in the brain, and how can that influence and future suicidal attempts in children or adolescent. Some of these can also serve as biomarkers, and therefore I think there's a lot of interest in looking at the neurobiology. While personally I am interested in neurobiology, but I somehow feel that neurobiology has still not reached a phase where it can really inform clinical practice. So I'll leave it there and I'll not really discuss too much about the neurobiological aspects. One of the common models that we discuss about in suicide is the stress diathesis model, and within that it is important to understand that the distal risk factors such as adverse childhood experiences, family history and impulsivity significantly predicts and differentiates attempters from non-attempters. While we do look at the life events, psychopathology and substance abuse, it's important to remember that adverse childhood experiences can pose a significant risk factor. I'll talk a little bit more about this later in my slides. Of the psychological theories, one of the most studied is the interpersonal psychological theory. So they talk about this unmet need to belong, which I commonly see in many children who come with emotional disorders. Especially so among adolescent females, it is said that this unmet need to belong and the sense of burdensomeness among the adolescent males is something that contributes to suicidal ideation, suicidal attempt. What adds to this is the acquired capability for suicide, because a lot of children who are exposed to repetitive or progressively repetitive emotional stimuli at home, or like repetitive self-harm over a period, seem to have an increased threshold for pain and a reduced fear of death over time, and this also seems to contribute to the evolution of ideation to attempt. As a clinician, it's important for us to know how psychopathology is associated with suicide, and so this is one of the meta-analysis which looked at studies from low and middle income countries, and this included about 25 studies from India, and this saw that whether it was fatal or non-fatal, mood disorders contributed a significant number of suicides as expected. Among the non-fatal suicide, anxiety and substance abuse also contributed. Now let me talk about how are adolescents different from adults, and why is that we are worried about adults, and why is that this number is so high among adolescents. In the adolescent, the limbic projection develops earlier and the cognitive control of emotion behavior develops later. And therefore, their ability to cognitively control when there is an emotionally charged situation, it's definitely significantly less as compared to an adult. They are also more reward sensitive. They're prone for immediate gratification. We also know that the dopamine receptors distribution is slightly different from that of adults, and there is also an influence of the hormone on the frontostriatal pathway. So all these things put together makes them neurobiologically vulnerable as compared to adults. When we look at the behavioral phenotype of an adolescent as compared to a child or an adult, there is significantly more sensation seeking in the adolescent. Similarly, there's also significantly more impulsivity in the adolescent. Now, while we think that there is an overlap between sensation seeking and impulsivity, it is said that these two are different elements, and when these two come together, it also poses a unique risk among adolescents. Within the psychological factors, the sense of self is still evolving among adolescents. They're more worried about other people's opinion about them. They're also looking for autonomy, and you know that in the Indian parenting style, there's a lot of parental control, and therefore they're more prone for need to control and need to decide what happens with their lives, and they're also more prone for peer influence. And so this changing role, responsibility, how relationships play out in their lives, and how do they respond to the expectations of the teachers and the parents around them also seems to have an impact on what happens within them. Like ma'am said, within our culture, I think exams, school-related stressors seems to contribute significantly to adolescent, although we seem to undermine that. Exams and bullying at school seems to play a huge role as stressors, followed by interpersonal issues at school and family. In fact, one of the studies which examined the suicidal rates in particular season found that it was significantly more between April and June, when children usually take up exams and the outcomes of exams come out. I just wanted to highlight this importance of adverse childhood experience, because a lot of studies have found that those genes which are associated with severe suicidal attempts are also associated with severe physical abuse. So quite often when you come across children with a history of sexual abuse or an history of emotional abuse, it is important to remember that these children are much more prone for suicidal attempts later in their life, because when they are exposed to abuse during sensitive periods, it definitely has an impact on their brain. So when we talk about early childhood life events, we are not just talking about the psychological impact that it has on the child, but it also seems to have epigenetic perturbation within the brain and therefore contributing to cognitive dysfunction. And sometimes they also result in acquired methylation changes which may have a bidirectional effect. So there is a lot of focus now on the epigenetics and about how genes and environment come together and may play together. And this is something that we need to keep in mind, that we need to look beyond the impact as a psychological perspective to the impact that it can have on the neurobiology per se. See, while we talk about, when we talk about adverse childhood experience, we often talk about abuse. But I think we come across a lot of things within our psychiatric setting, like mental health issue in a family, like a parent having a mental health issue, substance abuse within the family, and the other things that follow because of that, like domestic violence, parental separation, or a family member attempting suicide. All these can also contribute as adverse childhood experiences. And whenever we see a parent dealing with all this, I think it is important that we can, some level, contribute to promoting and preventing the mental health issues in the child. When we say adverse childhood experience, we are talking about anything which affects a sense of safety, security, and bonding for a child. That's what they really mean. So a lot of these can actually happen within a family, and I think there's scope to do a lot of preventive measures when we talk about these things. I'll quickly move to the temperamental aspects. Impulsivity we definitely know, strongly associated with lifetime suicidal attempts. There have also been studies which looked at the prevalence of emotionally unstable personality traits and uncharacteristic traits among people who attempt, youths who attempt suicide. Although there was no gender differences in the intent and impulsiveness, they saw that past history of anger and physical aggression was significantly more among males. In my study, when I looked at anxiety disorder, even within the group, I saw that although the life events was the same between the male and the female children, the stressfulness score was definitely more in the female children. So each abuse, each life event is given a particular score, and some of the life events are given slightly higher scores as compared to the others. And therefore you see that the female gender per se may be exposed to significantly more stressful events as compared to the males. And I think we need to see that in a non-biased manner, because I sometimes see that there's gender bias in the way we culturally evaluate kids. Quickly to the cognitive factors. A couple of interesting things that are coming up is the anxiety sensitivity. While we know anxiety has a trait, they also talk about anxiety sensitivity index, meaning the fear of anxiety related sensations and how they respond to that in terms of in suicidal attempt. Cognitive inflexibility is a very interesting element While I see this much more among adults, I don't see so much in adolescent, and I think the flexibility in the cognition is what gives scope for psychosocial interventions for adolescents. Lastly, the affective processes. Emotional dysregulation is something that I wanted to mention. Like we saw that neurobiologically also they have difficulty in regulating the emotions. But we need to understand that when an adolescent has had an insecure attachment, especially of the disorganized subtype, they are more prone for emotional dysregulation. Oftentimes, those children who are branded as emotionally unstable personality disorder, when I see that these are children who actually had insecure attachment and therefore are emotionally dysregulated when they get into another relationship during the adolescent. And therefore, it's important to understand that insecure attachment of the disorganized subtype can also mimic EUPD traits. Hopelessness, I think, is another element we usually, as part of adult psychiatry as well, we do assess as part of our risk assessment. Lastly, the peers, they definitely have an influence of peers. So when there is a friend attempting suicide, we do see copycat suicides. So the social learning theory is something that people talk about, which could play a role among adolescents. We also have to remember that while the intent is low in some of the adolescents, they may choose a method which is lethal, or sometimes vice versa. So when we assess lethality among adolescents, it is important to understand what the child's perspective of lethality was. For example, I saw a child who just took 4 paracetamol tablets, but in her perspective, she thought 4 was like 4 times as much we normally take, and therefore it is lethal. So it is important that you assess the lethality from the adolescent perspective. So all the pieces put together, so we have the neurobiological aspects, the serotonin, GABA, HPA. We have the psychological elements, emotional disconnect, insecure attachment. We do have the life events coming together, exam, interpersonal issues, abuse, romantic relationships, breakups, impulsivity. So all these factors come together to play in a vulnerable adolescent developing brain, and therefore can result in a complex suicidal behavior. So going on to the conceptualization, from a developmental perspective, it's important to understand that generally before 10 years, suicidal ideations are rare, and before 12, the attempts are less. Not that it's completely absent, it can definitely happen, but then generally that's how it's seen. And it is also known that ideation always precedes attempt, and roughly in many children it takes a few years before the ideation actually translates into attempt. Although some of the Indian studies say that within about half an hour, 1 hour, some of the children can proceed on to an attempt. No gender differences occur until about 11 years, but it is generally seen that there's an earlier age of onset when it comes to ideation, and earlier onset of attempt in boys, and ideation among girls. We know that half of the psychopathology starts by 14 years, almost 3/4 starts by 25 years. So if you've crossed 25, you're probably fairly safe. So it is important that when we see an adolescent, we assess and look for new onset disorders, especially mood disorders, and we also look for comorbidities. Oftentimes, I'll just explain this in the next slide. Oftentimes, in adult psychiatry, when you see a person with depression, you always almost assess their risk for bipolar depression, and then you keep a watch of what to expect later. But in child psychiatry, in child and adolescent psychiatry, we also look back to see, had this child had other disorders before this? Because in our culture, I see that oftentimes the earlier disorders go untreated, that the ADHD or the social anxiety did not really receive the attention, and they're now coming to you, and even though the depression is mild to moderate, what is complicating the issue is the pre-existing ADHD and the anxiety which is adding to it. And in a child, if this is also compounded by an insecure attachment or a loss event, then the picture can be really complex. Sometimes there can be subthreshold symptoms, like there could be pre-existing subthreshold symptoms of ADHD or social anxiety, which was performance, and therefore didn't really receive attention, but then when they land up to you, they really land up to you with a crisis. So when these things come together, we assume that it may have an additive effect, but a lot of times it has a multiplicative effect. So you have this impulsivity, you have anxiety, you have depression, and you have a loss event in a child who is vulnerable, and therefore all put together has a multiplicative effect, and therefore you'll have to see the child from that perspective. So moving on to clinical assessment, keeping all this in mind, I think routine screening is definitely important. A lot of times I've seen that although it was a self-harm attempt which initiated the consultation process. Parents do not often discuss about the self-harm attempt at all unless you really ask for it. And asking does not foster the idea. So it is important to understand that it is okay to ask the child, and actually it gives them an opportunity to discuss about the self-harm concerns. For youngsters the mini kid actually gives a way of asking. So if you're worried about how do I really talk about self-harm or suicide in an adolescent, it gives a method of how to approach and how to ask a child questions. For example, usually start with, do you ever think life is not worth living? Have you ever had thoughts of hurting yourself? And then move forward. You will see that a lot of time children do say that they have had such thoughts, and they felt that life is not worth living, but they've not really had any active plans. And then it gives an opportunity for the child to discuss why this is happening and how could they manage that. When possible, we could definitely apply scales. It is also important to understand that in a child with depression, this pervasive low mood that we often see or mention in the adults may not be there in an adolescent, because in a clinic you may see that the child is quite reactive and otherwise okay, but historically you see there are significant changes in his behavior. So although pervasive low mood is not there, don't be misled and keep a watch for evolving mood disorder. So you may think that depression is not completely evolved right away, but then it may still be evolving in this child, and therefore it is important that you keep them under follow-up, even if you're referring them to therapy, and watch for worsening over the next few weeks. Some of the cultural aspects. See, culturally, this attention-seeking behavior is one of the, I think, most abused word in psychiatry. All non-medical, like people mentioned, the non-psychiatric medical people always use this term, attention-seeking, irrelevant talk, for any referrals. So a lot of families think that these are attention-seeking behaviors, and they often see that it's a mere threat, but it is actually a cry for help. Even if the child is doing for some sort of a need that they think the child is doing, why should the child really do this? So I think it's important for families to see that it's a cry for help, and then they have to prioritize safety over stigma, that they're still concerned about stigma, even when the child is attempting suicide, which is really shocking for me. And I tell them that it is important that they prioritize safety, and that stigma is not, what is that stigma they're worried about? What really are they worried about? And that this is something that we truly need to worry about. When they see it as a threat, they're worried about the stigma. But when you really say that this is something that you need to take seriously and then prioritize safety for the child, then I think they kind of rethink about it. Many families do not really understand that things worsen over time. This policy that things improve over time. Poga poga seriya pairum. That happens with any child psychiatric disorder, so and so for this also. So they have to be told that there are disorders which definitely do not improve without timely help. And this is something that definitely really needs timely help. When you discuss risk-benefit, earlier on when I was young, I used to discuss about the benefit of treating the illness. But nowadays I discuss about the risk of not treating the illness, because they should really understand that what could happen if you leave this untreated, that if timely help is not really offered to the child. And it is more important to explain that adolescent has an age itself, that this brain itself is more prone for impulsivity, and therefore they can't take a chance even if they think it is just a threat. Because certain things are best prevented and cannot be regretted, because I've seen families who go through that. I'll just talk about a case scenario to help you understand about how Indian parents are and react, and not that it's anybody's fault, but that's how we function. Like I said, we often see this disconnect, and oftentimes it's ambivalent. It's not this child is very upset with the family, they're angry with the family. It is about they really like them, but they're also angry about certain things, or they have this inability to discuss some of the things with the family. So I had this adolescent with depression. He also had ADHD and SLD in the past, ongoing, but then it was never evaluated. Somehow went through 10th because of the corona, and then he landed with me just before the plus 2 exam because he was super anxious. This child actually had SLD for arithmetic, and they put him in commerce group, which was all the more difficult for him. So he was super scared to take the plus 2 exam. This child also had non-suicidal self-injury, a lot of marks in the hand, and that was also not, they also didn't seek help for that. So just before the exam, he had a self-harm idea, and then they brought to us. So we treated with medication, we did put him for counseling, and then he kind of appeared for the exam with the support and hoping that they would give corona all pass. Unfortunately, there was failure, and there was re-emergence of self-harm ideas. But family still kept persisting on repeating the exam because they thought that they were more concerned about his future. Now I had to really explain the risks to the family, the age, the proneness for impulsivity, the past NSSI, the current failure, There was also this background of parental discord, so one parent was not involved in the treatment at all. And this in SLD and the genuine inability of the child to cope with the academic difficulties and this need to please his mother. Although the child really did not could see that this is not possible for him. He almost got single digits and he failed in 5 of the 6 subjects. And so it was very clear to me that this child, it will be very difficult for the child to take. And what he did was appreciable, and I think we should let it be there. But then this inability to voice his inability, right? That there was somewhere that need to please the mother by giving the exam. And so this child kept trying, and it was very hard to convince the parent that although she was concerned about the future, I had to say that he has to have a future for you to be concerned about it. So somewhere you need to put things together to really help them understand that these issues are there and it is not as easy as you think, like you can அப்படின்னா நம்ம ஊரில் திட்டினா படிப்பு வந்துடும், அடிச்சா படிப்பு வந்துடும். You have this kind of a policy, but this is not like that. And you really have to understand the various things that are going on for this child. So when a risk assessment, we look at the subjective unit of distress. Oftentimes you talk about visual unlock scale. A lot of children understand that. You talk about 0 to 10. 0 is nothing, 10 is full, 5 is medium, and how much is your distress. And that kind of gives the child an understanding about where the distress is and to communicate with you at baseline and at follow-up. And we also talk about what the meaning of that failure is or that life event is. So does the failure mean that I'm not good enough, or does that failure mean that I could not keep up to the expectation of my parent? Are there at-risk mental states like depression in this child? Is there a past history of suicidal behavior? Is there a current suicidal thought? And if there is, what are the coping potentials of the child? So we always have to ask, what is that would you do? Even if the child says that, no, currently I don't have a suicidal thought, always ask, what is that you would do if you have a thought? And whom would you like to talk to? Where would you like to take help from? Who is available for you to support? So those interested could read this model. It's the zero suicide model, which gives you some idea about how to assess, intervene, and monitor. I'll just focus on the intervention aspect. So when we discuss the intervention, we bring about a collaborative safety plan, talk about internal coping strategies, like we said, about what could help the child distract himself if at all there is a distress, and whom could the child talk to within the family and with a professional, and how to make the environment safe. Safety measures, very important. I think not to ignore as mere threat, like we discussed. And I think these are things that I think you would do even for an adult patient. I'm just quickly running it through just for completion's sake. So you definitely write and document that you advise 24/7 monitoring, no loose cloths, sharp instruments, medication under supervision, kept under lock and key. Oftentimes you advise them to keep under lock and key the medication that you prescribe, but there would be other medications other people in the family are taking, which also needs to be supervised. The importance of sensitive and supportive parenting. So I explained to the parents that children with with depression can be more prone for irritability. So even if they're irritable or angry, I think it's very, very important that they continue to be supportive and not tip the balance off. Because many a time you offer IP care and they're not willing to do the IP care. So it is important that you do all this and then document in your chart. Quickly about the SSRI, because we are also concerned about SSRI and suicidal ideas, but we need to remember that the absolute risk for suicidal ideation with SSRI is only 1%, and the risk for switch is about less than 2%. So when you compare the risk of treating as compared to the switch, I think there's definite benefit with treating with SSRI. Behavioral activation is definitely less among adolescents and those with depressive disorder. So I think it is important that we consider SSRI, because SSRI not only treats the illness, it is said that they also contribute as epigenetic modifiers, and therefore we need to keep that in mind while we offer treatment. But it is said that when you do combination treatment, that you do SSRI and therapy, it always kind of helps the child in addressing the evolving suicidal ideation. The problem occurs when you have children who are probably at risk for bipolar. So you have a family history of bipolar, or you have this past history of ADHD or impulsivity, or you have this evolving EUPD, and then you're worried about how do I really do the SSRI, can I really do? And then I think it is important that we make this judgment of combining SSRI with a low-dose antipsychotic drug and then keep them under weekly follow-up. Ketamine, there are some studies on ketamine. Seems very interesting, but I don't think there are enough evidence as of now. But there are few studies which has looked at intravenous ketamine, 0.5 mg per kg. those interested could read about it. It's very interesting theoretically, and there also seems to have some short-term effects with ketamine. But I think in terms of approval, I think it still has a long way. Psychotherapy, CBT and problem-solving therapy. Although in many resource-limited settings, we may not really have the resources to deliver all this, problem-solving therapy and simple CBT techniques can definitely be offered. There is this thing from MS Ramaya where they do this 3-session outpatient work with those who had attempted suicide, and they felt that within the 3 sessions they could deliver some of the key elements like problem solving and addressing some of the key automatic negative thoughts. And they found that over the next 6 months there was significant reduction in the suicidal attempts. So although we feel that we may not have resources, it is important that we try and make sure that the child is in touch with somebody for proper therapy as much as possible, or at least a brief intervention that you could offer in terms of CBT. There are a lot of clinical challenges because oftentimes they end up in a crisis, and you will see that medication alone doesn't help. You plan therapy, but you also see there's a lot of other psychopathologies in the family. So oftentimes they need a combination of many therapies, and you do not really have that sort of specialized care unit to offer all that. And with the ECT requiring approval of Mental Health Review Board, it becomes even more challenging. Novel drugs, although very fascinating, doesn't seem to have enough evidence. So I feel that it is definitely a challenge for clinicians. But what I felt is that it is important that we go beyond neurobiology and look at potential predictors, not just the current picture, but also the risk factors such as adverse childhood experiences, impulsivity in the background, and I think most importantly, enhancing the protective factors. For example, the emotional connectedness within the family, enhancing secure attachment within the family, and promoting mental health. I think promoting mental health not only for at-risk children, but I think it's important for us and for our own children. Somewhere we think that we are all immune to mental health disorders. None of us are. So I think it is important somewhere we bring this element of promoting mental health in whichever child or adult that we come across. I'll just end with this. Sometimes it is said that focusing on protective factors is much more important than reducing the risk factors. So I think it is important that when we look at the risk factors, we also enhance the protective factors. I really thank the organizing committee for this wonderful opportunity, and my special thanks goes to all my teachers from Madurai. I will not be standing here without them. Thank you.
Thank you, Preeti. It was a very wonderful presentation. Now we understand that adolescent suicide is not dealing with them on that point. A lot of factors are operating, starting from childhood, attachment issues, child's abuse. It can be of any type of abuse, and the finally end up with the neurobiological changes. So the prevention of adolescent suicide starts from childhood, and also with the educating the parent also, and broader application, it involves the educating the parents and teachers about how to prevent abuse and how to encourage attachment with the main figures, and also in positive thinking. And personally, one-to-one, when it comes to one-to-one therapy, a lot of things can be offered to the adolescent by the psychiatrist, and by understanding these lot of factors, adolescent usually doesn't open up normally openly about their issues, and if we understand if these factors will be present in them, we can slowly probe them, we can make them comfortable and bring out what factor is operating in them. There may be many factors, but for that child, what factor is operating, we can probe them in one-to-one approach, and certainly we can try to find out a solution and can go on for prevention for that adolescent. It was a very wonderful presentation, and it will be very helpful for the postgraduate students. Thank you, Preeti. On to...
We have time for one question from anyone from the audience. Karthikeyan, keep your question brief, please. Thank you.
Karthikeyan from Madurai. I'm a proud teacher of Dr. Preeti. The thing is, I come across patients who have attempted adolescent suicide. Two kinds of patients I have come across. One kind of patients have an identifiable mental illness. Another set of patients
In adolescent suicide attempt tests, I come across two kinds of the patients. Some patients have an identifiable psychiatric illness, and some patients, we find it difficult to, some people try to force a label on them, or they cannot be pigeonholed into a separate diagnostic criteria. When these two sets of patients come across, I find it better to treat the patient who has an identified mental illness than a patient who is supposedly normal. What's your experience been in such patients? And another question, the second question is, I've often seen patients who have attempted suicide who has behavioral problems having been treated with antipsychotics. But we often talk about SSRI's potential to cause a suicidal risk. But at the same time, antipsychotics often, when given higher dosages, I've seen patients who have gone in for antipsychotic-induced dysphoria and their condition having been worsened. Sometimes reducing the antipsychotic medications itself have found to have helped the patients. What is your experience regarding this?
So two things. The first question that you mentioned about the attempts, and so I do agree that sometimes we are not really able to give them a label as a mental health disorder. But knowing that suicide attempt in itself can become a risk factor for future attempts. I think it's important that we put them in touch with a therapist who can give them problem solving. What is that? Why is that they chose suicide as a method of coping, and why couldn't they think about alternative methods and how to help them problem solve the situation? Somewhere that the child felt that the situation was inescapable. So could somebody help? So it may not be a psychiatrist, but can they be put in touch with a psychologist or a social worker when available? If not, can we then go to that one extent forward to see that even if it's subthreshold anxiety, that not really fitting into a disorder, can I still do some problem solving therapy with the child, even if it's like single setting or 2-3 setting, which usually happens. They take discharge and come back. So this 3-session model seemed very interesting for me because I felt that if we can offer that one small element to the child, it could make a difference in terms of preventing another attempt in future. That is one. The second thing, I totally agree that quite a few times I've seen children put on antipsychotic or even mood stabilizers because they're worried about the risk of thing with SSRI. But that's why I put up that SSRI really do not pose that sort of a suicidal ideation risk, actually. In fact, after the introduction of SSRI, globally there was a decrease in the number of suicidal attempts and suicidal rates. In fact, after they introduced the warning for SSRI, again the rates went up. So it was an indirect indication to say that SSRI is actually helping children. So we can do SSRI, and if there is a worry that there is impulsivity or there is this at risk for bipolar, that you're worried about switch because of family history or other reasons, we could add on to the SSRI only a low dose, like 2 milligram equivalent of risperidone, which could then keep a check on the possible switch or the impulsivity. So you write the indication, what is the indication, so that it is not continued forever and you can pull it out later when therapy takes over.
Thank you, Priti.
Thank you, sir.
One more question. We have time for one more question. Is this mini kit, is it available freely? Can we download it, or do we have copyrights for that?
Ma'am, I think for research and clinical purposes we are allowed to, but I think we need permission for research to write up to the thing, but usually they allow, for non-funded research they allow. So, and I found that it's very easy for PGs. It really gives you the method to how to ask and how to really, you can't suddenly ask about suicide. So you'll have to really proceed slowly, and it really gives a framework of how to ask.
And the other one also, the TASRA, is it also?
That is available online.
That's available online, okay. So thank you very much, Dr. Preeti. We'll conclude the session. Thank you very much to the organizers.
Now it's time to honor our chairpersons. May I request Bhagisri ma'am to honor our chairperson, Shanti Nambi ma'am. Thank you, ma'am. Now I request Preeti ma'am to honor Gitanjali ma'am. Thank you, ma'am. Now it's time to honor our speaker. I request our chairpersons to honor our speaker, Preeti, ma'am.
Thank you, everyone. So with this, we have come to the end of today's sessions. So we can now move on for dinner. And tomorrow, I request one and all to assemble here by 10. Thank you.